Welcome, everybody. We'll wait a few seconds before starting so everybody has a chance to come in. All right. Welcome, everyone, to Renegade Research Clinicians Roundtable. If this is your first time with us, thank you for joining us. And of course, thank you to our loyal attendees. I am Isabel, CEO of our organization. We are a patient and caregiver-led, decentralized 501c3 nonprofit. We focus on complex, multi-system chronic conditions such as ME/CFS and long COVID. Within this, we have three areas of focus: research that's agile and patient-centered, education to increase the number of clinicians treating us, and practical advocacy around barriers to care. Our work is made possible by a wonderful team of volunteers who move the wheels of our organization. Most of us have personal interest in advancing research and care of these conditions. You will see our volunteers, some of them, this is not an exhaustive attendance, of course, but some of our volunteers are on the panel. To stay in touch with us and hear about upcoming events, please subscribe to our newsletter and follow us on social media. We are most active on X. We will be posting the links for you to have handy throughout the presentation. Our work depends on donations of all sizes. You can help fund our work by donating to our funding campaign and also by sharing our campaign with others who can donate. Visit the event page of our website, renegade-research.org, to stay on top of our upcoming events. Today's roundtable is with our Chief Medical Officer, Dr. John Haughton, and Josh Leisk, who is the creator of the BornFree protocol. This roundtable is intended for informational and educational purposes only and not to be taken as medical advice. Please consult a qualified healthcare professional if you wish to implement any changes from the information that you learned today. And with that, I will hand it to John and Josh to get us started on the today's roundtable.
Great, thank you, Isabel.
Thanks very much, Isabel.
You're welcome.
Share and just double check that sharing is working as it should. Are people seeing this full slide set or full
All
slide?
good. Yep, all good.
Yep. Okay, great. So Josh Leisk, who's created the BornFree protocol and runs a robust internet presence around it, as well as other ways of distributing the information, has been kind enough to share time with us to walk through the protocol and how it works, why it works, and so on. And the idea of the discussion today is to keep it straightforward on the biochemical pathways, but also to try to bring it to the clinical place of, where is a person, what are their needs, how do they know something's happening with it, and so on. So we'll try and go back and forth with that, and he and I will speak collectively on some of the slides here.
Thanks, John.
Okay, so I mean, first of all, the overall key thing is that, given the chance, the body's going to get to a balance of homeostasis where it's working. And it can only do that if it's perturbed or pushed away from balance, if there's enough energy and resources to put to bear to bring it forward. And that's going to be a common theme. We're going to... Go ahead, Josh. Yep.
Yeah, that's essentially it. I mean, homeostasis is the golden rule. Everything sits underneath that, and the system is always trying to bring itself back into homeostasis, but there are limiting factors that prevent that from happening. So resource shortages and chronic insults essentially are the main challenge, but then also potential, maladaptations, nervous system alterations, things like that. So anyway, back to you, John.
Yeah, and so today what we're going to do, we're going to describe the protocol and why it's needed and how it works with ME/CFS, in the same discussion could point to any specific trigger disease around it. Share information about the protocol stages and timelines, and then importantly, answer questions and engage in a discussion. And as Isabel said, this information is for education, and it's not medical advice. It's really important for treatment decisions to be made between the patient and the providers, their own medical providers.
Excellent. So I can jump in, I guess, at this point for a little while. So when we're thinking about ME/CFS, there is a huge parallel to what we also think of on a much slower pace as aging, or the nature of aging. If we look at it from a long enough timeline, we can see that the parallels over, say, 50 or 60 years are going to look very similar to what can happen in a very short time in ME/CFS. And ME/CFS we can also look at as being a state which has a number of different catalyst events, which lead us into this state. But ultimately, prior to this catalyst event, there are a number of things going on before that trigger. So when we're looking at the burdens, there can be a number of different things. We can be talking about toxins in the environment. They're part of the background ongoing insult. We can talk about toxins being generated by the microbiome. We can talk about toxins being generated by circulating pathogens that might be in biofilms. And we can look at a number of other things like microplastics and things, which are also contributing to some of the the ongoing difficulties in maintaining homeostasis.
I think just emphasizing that point, one of the things that happens is people have an event that says, oh, after this infection, or after this head injury, or after this traumatic event, I all of a sudden had the fatigue, had the post-exertional malaise, just exhausted, couldn't do brain fog, and so on. And this layering is in why potentially is there more of this going on? And it turns out that the receptors, the danger receptors that respond to pollutants, that respond to mold, that respond to microplastics, that respond to viral spikes in spike protein and in Lyme, and all of them together, they all get turned on slightly different mechanisms, but in a similar way, and put increasing pressure on the inflammatory process, which is an important fixing process in the body, but it can get out of whack. And that's what we're really talking about here, is when it gets to the place where it's stuck on and can't turn off.
All right, next slide, I guess. Oh, we can touch on that too. There's part of that shift that we're talking about, and that's probably sort of, I think, was really highlighted during COVID, was this shift towards the HIF-1 alpha signaling. So when we see problems with the microvasculature, when we've got problems that lead to viral reactivation, then we see this shift towards lactic acid metabolism. And that's something that's kind of critical to progression of the actual disease state as well. But it is it's a really interesting pinch point in the metabolism. We'll go into that in a little bit more detail further along. One of the big shifts and one of the big variables is the microbiome. We focus on the gut microbiome here, but ultimately this can be a number of the other microbiomes. All of the mucosal tissues have microbiomes. There's an argument at the moment that the brain has a microbiome, and the evidence for that is quite interesting. But the microbiome can be in a normal balanced state, and there's of course a symbiosis between the microbiomes and the host. The microbiomes in many ways act like an organ. They produce 100 times more metabolites than our own liver can, and the actual number of microbial cells outnumber our own significantly, depending on whose data you want to look at, between 4 and 10 to 1. So when we're looking at the microbiomes, we have bifidobacterium being one of the key players, and that's normally seeded well, very, very early on in life. Some of the data that I've read suggests that a baby's microbiome consists of about 80% bifidobacterium. A healthy adult, if one of those exists, is around about 20% bifidobacterium, and then in the ME/CFS or chronic disease space, it's anywhere between 0 to 4% bifidobacterium. And these species have some key roles in managing the number of other unpleasant microbes that might also be in the system, biofilm degradation, and a number of other functions. But also can help with the metabolism of certain toxins and things. They're like the temple guards and the janitors. So when they're low, then a lot of the burden falls back to the host to manage some of these other issues. Um, the inflammatory burdens. So looking at the diets, I mean, there's been some great data on that in recent times, and also how that relates back to the microbiome. So there was a paper that talked about how the Western diet blocks microbiome recovery after antibiotic use. And that really was, I think, a wake-up call for anyone that thinks that they're going to be able to recover their microbiome while, essentially existing on a very limited diet to try to avoid the inflammatory response that might be noticed, or definitely will be noticed when recovering the microbiome. So any of the movement or the shift back towards an elevation of bifidobacteria is going to be triggering certain symptoms as that battle goes on in the microbiome. So yeah, the other side of that is the inflammatory cascade and how that manages the minerals. Hepcidin is a peptide hormone. It's mostly known as being the master iron regulator. The literature extends that out to 11 different metals in total. Manganese is probably the second highest affinity for the transporters downstream of hepcidin. So that's divalent metal transporter 1 and ferroportin. Hepcidin, when it elevates, it ends up inhibiting the two mineral transporters. And yeah, that essentially blocks the dietary absorption of these minerals at the same time as sequestering the circulating metals. We'll go into that more later. The canary in the coal mine, of course, is the low ferritin or low systemic iron, and that's seen in quite a high percentage of the population. I think that's a very good indicator for, yeah, somebody who's in a chronic inflammatory state. Next slide, please, John. The other key, I suppose, key variables relating to age progression and chronic disease relate to NAD and aldehyde metabolism. And these two, NAD famously, we've got David Sinclair, who's been, talking significantly about NAD for quite a number of years. The aldehyde metabolism, which sits in part downstream of the NAD metabolism, but is also critical for, there's a bit of a loop around managing that NAD metabolism, is something that we're going to touch on quite well, I suppose in some detail in today's presentation. So the NAD decline, we know from aging studies that the intracellular NAD levels are decreasing with age. But we also see from a number of ME/CFS studies and long COVID, there are significant issues with the NAD status. One of the key enzymes which requires NAD is aldehyde dehydrogenase. So aldehyde dehydrogenase is multifunction. Aldehyde dehydrogenase number 2 sits inside the mitochondrial matrix. And it'll take aldehyde, so for example, like acetaldehyde, and it's going to convert that into acetate. ALDH2 performs its role for a number of different substrates, quite a wide array of substrates. So if the mitochondrial matrix has a low NAD pool, then the ALDH2 enzyme is going to end up becoming inhibited or downregulated, impaired. So in that state, what that means is that all of the substrates which need to be metabolized by ALDH2 get backlogged, and some of those, the aldehydes, generally speaking, are very toxic. Low NAD also then leads to a shift in the TCA cycle flux, and that can also then lead to a number of different compensations. But ultimately, if we end up with a state where the hypoxia-inducible factors 1 alpha ends up being stabilized, then we end up with a very interesting situation involving chronic reactivating viruses, but also some very difficult metabolism. It's something that is helpful in keeping cells alive in adverse states, but it is ultimately something that has quite an impact on the overall system, like creates a burden of its own. So bursts of it is great, chronic is not so great.
And from a clinical perspective, you could think of HIF-1 getting stabilized, and when that happens, you get these certain things produced, and it gets stabilized when it's hypoxia, when there's not enough oxygen. And one of the reasons you can't clinically just completely treat to one extreme or the other, the teeter-totter, is you kind of need both parts. So HIF-1 increases inflammation, but it also increases development of new blood vessels. And so, why intuitively or from a functional perspective, why would you want inflammation to go on when there's not enough oxygen? Well, inflammation can tunnel under tissues and bring in new raw materials, and that's exactly what happens. So, if you totally flip the teeter-totter from HIF-1 to NRF2, then it's hard to grow new blood vessels. And that happens in chronic wounds. And it also happens sometimes in these metabolic states we're talking about here today. But the take home is not all one or the other.
Balance. Yeah, I think it's really interesting because if you look at it, a lot of that metabolism, when it's triggered, it ramps up a response, which is supposed to be basically making the host more resilient. The problem is, again, that balance. If it's too much one way or too much the other, then we fall out of homeostasis. So, yeah, I think in this slide, the highlight is again that we have the exact, well, almost identical metabolism between someone with ME/CFS in their mid-teens and somebody in their 60s and 70s who basically just has lived a normal life, which really to me suggests that we're looking at ME/CFS, or should be looking at ME/CFS as advanced aging in many ways. But it also suggests that a successful treatment for ME/CFS has applications in the longevity space, and I think that probably is something that needs to be really highlighted. So yeah, the endpoints as discussed here, we have elevation of aldehydes, we have the mineral dysregulation, we have low NAD, we have pseudohypoxia and hypoxia. Cholesterol elevation is essentially a really interesting inference for aldehyde or ALDH2 inhibition, and the collagen synthesis issues that we see as hypermobile Ehlers-Danlos syndrome, but we also see just as part of quote unquote normal aging in the elderly. The immune system response, of course, is common to both. So I would look at anyone who has ME/CFS as being immunocompromised, and in a similar way that you would treat anybody who is elderly, you would think that they have a less functional immune system, and it's just a progressive spiral. It's just where you sit on that spiral. So, yeah. Well, we've kind of just highlighted all of those, John. But yeah, we could probably skip that slide, I guess.
But these are the take homes. So the pathways are complex and they interact, and there truly are hundreds of pathways, and depending on how you count it, you can get up to thousands. But broadly, you've got to control hypoxia, you've got to control the minerals, and the gut playing with the body is a huge part of that. The aldehydes are critical, and if it doesn't have energy supporting it all, there's no way it's going to happen.
Yeah. I mean, the aldehydes, most people, well, some people do realize that a number of the key pathways all have aldehydes. So we have like the B6 metabolism, pyridoxal is an aldehyde. We have vitamin A metabolism, retinal is an aldehyde. We have like the monoamines and the diamines. We've got like the neurotransmitters, histamine. All of these they all have aldehydes in the pathways. So when we start looking at things like mast cell activation syndrome and the neurotransmitter dysregulation, we're looking at the aldehyde metabolism dysregulation. So it is quite a broad landscape when this metabolism is problematic. And there's a really interesting side pathway which gets triggered when the aldehyde metabolism becomes dysregulated, and that is actually the endogenous opioid synthesis pathway. So this one's really interesting. So when dopamine and dopamine's metabolite, which is dopal, end up being elevated, that elevates a pathway which is driving endogenous morphine synthesis and a number of other opioid alkaloids. So it starts off at THP and salsolinol, and ends up down a S-reticuline pathway towards the codeine and morphine. So the body is able to produce all of these opioid metabolites, and of course that has the normal effects of agonizing the opioid receptors, but it also has some interesting effects on cAMP, so cyclical AMP. And downstream of that, another a mechanism called CREB. And this is really interesting because cAMP and CREB, we see two opposing pushes. So this is this homeostasis becoming dysregulated. So we have the opioid metabolites inhibiting cAMP, and then we have the chronic fight or flight, the sympathetic overdrive, ramping up the cAMP signaling. So what we end up with is sort of all one way or all the other way, and no balance in between. The homeostasis is lost. And what's really tricky here is that the priming of the cAMP pathway, the alterations to cAMP from the opioid elevation, ends up setting up the system to be hypersensitive to any of the signaling, so the beta adrenergic signaling, but ultimately norepinephrine and epinephrine signaling of the cAMP pathway. So the morphine or the chronic morphine and the other related alkaloids end up setting up the system to be hypersensitive to like any of the adrenergic signaling. So it becomes very tricky. The nervous system itself becomes hypersensitive at that point and is trained to become hypersensitive by this chronic state. And all of this is known from, chronic opioid use. We can dive into the literature for, anything that's known from, both illegal drug users and just patients that have been on, long-term opioids. There's quite a lot of data to actually explain how this works. But the missing piece of the puzzle has been understanding that this actually happens endogenously and why it happens. So, John, did you want to jump into anything on this, or next slide?
I think just the tangible clinical piece of somebody going through withdrawals if they're on some various medications, including opioids, is one part of it. And what you're highlighting here is that because you can flip from one side the sympathetic drive and into the other side with the morphine signaling, if you pull away from the morphine signaling, you're creating that withdrawal just on its own. And that withdrawal is anxiety, fidgetiness, that feeling of unrest and lack of safety that is seen and sometimes seen as people are going through different stages of recovery or decrement in ME/CFS as well.
I think that's the key thing, is understanding you're having symptoms. People that are talking about neuropsychiatric symptoms when going on protocols or taking B vitamins or NAC or glycine or, even just little doses of vitamin C, all these different things that slightly alter the balance between the acetaldehyde and the endogenous morphine synthesis, and then suddenly get hit with, morphine withdrawal symptoms, having no idea that that's actually what's going on. I mean, that'd be an incredibly frightening place to be in. The symptoms, the extreme symptoms from morphine withdrawal, you can have tremors, you can have seizures at the upper end of the spectrum. But it's the insomnia, it's the tachycardia, and like the you really push into that sympathetic overdrive symptoms. So panic, terror are absolutely part of that, that suite of symptoms. So having expectations that that is part of that journey and how to manage that, it allows you to, go into that eyes open and avoid a lot of the unpleasantness.
And if you think about this, what Josh said at the beginning about the interplay, it kind of pulls, because of the way the system is set up with the cAMP and so on, that it's going to pull it to the one side or the other. And you can think of like a screen door. If you have a screen door that doesn't have its closer on it, you can open it, But if it has a spring, it just slams shut. Or if there's a big wind, it slams shut. There are lots of things that can make that happen. But if it has the cushioning device on it, then it slowly closes and slowly opens. And this clinically, that cushioning device isn't sitting there in a lot of places. And that's what we're talking about, trying to rebuild it and give more power to hold the door open or keep the door shut.
Mm. So this is the interesting part of CREB. This is where these two pathways end up coming together. So CREB being elevated or primed by the morphine ultimately makes the situation with the sympathetic overdrive significantly worse. There are a number of ways. I mean, look, we've seen, uh, you know, clinically things like beta blockers and ivermectin have been quite successful. People have symptomatic relief from a number of drugs of that nature. Um, I would say that ivermectin has probably had a better result with the ME/CFS patients over the last decade, because it kind of takes the peaks off rather than inhibiting the basal tone so much, which makes it a superior intervention. There are a number of other things that can be done in that space. From the botanical side, there's things like microdoses of Bacopa, which also can interact with CREB directly. And that's kind of a tricky one. That's something that we're looking at for a future update at the moment, and how that might be deployed. But it's able to bring up the CREB to a more balanced state, so that it's not kind of being as dysregulated by the back and forth all the time between the morphine and the sympathetic overdrive from the nervous system. So there's overall a gentle process that needs to be brought in to bring the balance back to the center, for the swing back and forth between the morphine and the sympathetic overdrive. Downstream
And
of
just
that,
one thing, and this is, we talked at the beginning about the importance of doing this work with your provider and with the sort of that local trust. And some of it is to have a sounding board of when something is going on, and when somebody may not be feeling as well. What's that about? And is it a red flag that something bad's happening, or is it an expected response? And they can look very much the same and feel very much the same. So
mm,
it's important to as these body systems are getting modified, and biochemical systems are getting modified, to just make sure that there's a place to have a good sounding board about it, and the importance of measuring with labs and so on too.
so additional inputs towards the inflammatory cascade. It's not just the microbiome, of course. We end up with circulating pathogens, so things that have gotten through the barrier and can set up residence. I think something that gets not enough attention would be the Lyme and some of the other related species. That we have, everyone's, I'm sure, come across Bartonella and Babesia and Borrelia. There's also Mycoplasma. There can be a number of other circulating species which are present, and they tend to go hand in hand, and they tend to get overlooked. And one of the biggest challenges has been diagnostics. It's something that I'll be doing some writing around over the next month or so. But there is incredible difficulties in getting reliable labs for the Lyme species. And hopefully we'll be able to give some guidance towards clinicians on how to actually navigate that minefield. The other pathogens which are common, we have the resident latent lytic viruses. So there's the human herpes viruses. So there's 9 of those. We now, of course, have SARS-CoV-2, and there's all of the usual seasonal viruses. Most of those are transient; they're in and out. It's the ones that set up residence. We also have HPV. Unfortunately, some people also have HIV. And these chronic reactivating viruses become part of the overall landscape. Beyond that, we have the mold, the fungi. These produce mycotoxins. Many of those are gases. If the environment is unfortunately not uh, not a happy environment, if it's full of mold, then as well as having the burden inside the host, you might also be suffering from a daily intake of mycotoxins just from the environment around it. So these are also able to be activating the inflammatory cascade. So these things need to be resolved as part of the the recovery journey.
And you
Trauma,
could, I was
yeah.
just going to say, you can really think of them as layers of pressure or additive
Mm,
components. So if you're getting by with mild long COVID and you end up in a moldy environment, um,
mm,
both of those are going to put pressure on the toll-like 4 receptor, and that's going to add more inflammation. So that thing that's helpful, hey, I'm fighting the virus and I've got I want my immune system working better, is now getting to the place where it's stuck in, hey, everything's inflamed and now not enough blood can get around, and so you're stuck in that HIF1 piece that was talked about before, and that can happen with from a receptor perspective with the air pollution. 2.5 micron air pollution particles trigger one of these receptors. The mold does, the microplastics, Lyme is TLR2, not TLR4. And then if you look at uh, in the long COVID period, we all of a sudden have a lot more respiratory syncytial virus, or RSV, and that also very specifically ties into and turns on TLR4. And so there's a reason we're seeing some of these things coexist as well.
and they accumulate as being the other thing. So the more severe you are, the more dysregulated the system is, the more these things accumulate like baggage. Um, Trauma is another one which is not also talked about enough. And it is interesting, there's a number of studies that show how the immune system is altered and primed by trauma. And it's yeah, it's something that I think is going to need a its own set of remediations. I think this is kind of where a multidisciplinary intervention is really required. Um,
Can you just confirm when you use the word trauma, some people might think of a car accident or getting hit over the head, but you may be speaking about a different type of trauma as well, just to point that
Yeah,
out.
absolutely. Psychological trauma, emotional trauma. So you could have grief, death, you can have abusive situations. There are a number of different ways that these can be imprinted on the system. And there's actually some interesting animal studies where they showed that trauma is something that is heritable. So there was, I think it was a mouse or a rat study where they traumatized the male rat, and also there was a smell, there was an odor that was also released at the same time as they traumatized him. And so the rat was trained that the smell was also traumatic. Well, I think it was a rat. It might have been a mouse. Sorry, but the what was interesting was that 8 generations of offspring that had no interaction with the father also inherited that trauma-like response to the smell. So there is an imprinting at a cellular level from trauma of many many sources.
And
Looking at
then
the
sometimes in the general clinical world, or you hear the terminology of PTSD or post-traumatic
mm,
stress disorder, and that really um, is sort of stuck in that fight and flight mode in many ways, the sympathetic part. And if you go back to remember where you had the opioid side and the sympathetic part, you're stuck on the one side. So the body is sitting in a place of anxiety and nervousness related to it, especially if there's a trigger. And then if you look through the U.S. veterans community, you had people who were exposed to things like the Agent Orange, which are environmental triggers, but in a time of lots going on where there could be PTSD of somebody seeing their colleague or friend uh, have an awful end from violence, and these things are hand in hand in hand. Or it could be in a family where there are differences with addictions, the alcoholic family, and so on. And the it's not just environment, it's not just psychological. And the challenge, I think, clinically is that patients can end up in a feeling of gaslit experience if somebody says, oh, well, it's just in your head, it's just psychological, but that's a pressure in this setting that has to be addressed. And equally, it's important to not just totally discount it and say it's physical, not mental. It's the mental is the physical, and the physical, they all intertie with each other.
And I
Hard to
was
separate them.
coming on camera just to put in that caveat, because I know what you guys mean, but I know that you know, being on video, there's a lot of ill-intention groups that take clips, you know, from pieces like this when we're talking about the systems holistically in order to continue that gaslighting, right? So it's important to understand that we are addressing the physiological and the biochemical components that the pressure of trauma causes, just like physical trauma does, because it has an influence in our autonomic nervous system. And it's, you know, it's an input, just like food is an input, just like a supplement is an input. Just so everybody doesn't take the liberty to take a, you know, a bit of that piece and take it out of context in what you guys are sharing.
Very important. Thank you, Isabel.
Yeah, thanks, Isabel. Just a thought there, John, too, looking at the time, we're going to have to speed through some things.
Yeah, no
So,
doubt.
I mean, I'm happy to spend longer, but yeah, let's
This one we talked about the commonality at the top turns these things on, and so the response that's usually a fix is at the heart of some of the ongoing problem. And then ultimately that you lose blood flow, you lose oxygen, and then that you've got at a cellular level the energy issues, switching metabolism from TCA cycle to glycolysis, and all of this ends up being the root cause behind the brain fog, the breathing issues, and the various organ systems involved.
one of the major influences, yes. Yeah. So this interesting state. We're going to dive into some of the biochemistry, or some of the key parts of the biochemistry today. So mitochondria are the amazing powerhouses inside the cell. You know, they're not just producing ATP, they run all kinds of other processes that are critical to the cellular function. So what we're looking at when we're talking about mitochondrial dysfunction in ME/CFS is, I suppose, the total lack of homeostasis in things like the redox, the inability to efficiently maintain electron flow to ATP synthase, the inability to maintain a balance between different currencies and their redox states, and many other things which are being controlled by the mitochondrial function. So synthesis for a number of different things, hormones, cholesterol, blah, blah, blah. So this this state of energy bankruptcy is not necessarily coming from a lack of substrate or anything like that. It's literally that there are cofactors and systems and redox states and things which are unfortunately out of balance and just can't keep up with the pace. So we end up with functional decreases in operation. So inability to activate, muscle tissue, brain fog, inability to synthesize collagen or otherwise repair systems. And then the nervous system dysregulation that we were going into a little bit of detail before. So anything to add here, John? No, here we go. And ultimately, this state we need to be able to return from. So to do that, it's a bit like picking up Humpty Dumpty, who's in 50 pieces on the ground. We need to put all the resources back into the system while the system's actively fighting it, and we need to do our best to reduce the burden of the insults. We need to bring as much of the toxicity down so that the system can restore itself. And while it can't do that, we kind of need to be managing all of the different systems. We need to put all these different resources back in, the 100 different fuels that the body's needing, bring it all back up to at least a somewhat functional point where the body is able to take over and then restore that homeostasis itself. And it reaches a point where if we then, keep interfering, beyond that, we're getting in the way of the body's own natural homeostasis. And so that's also an important part, is that transition back to allowing the body to do it itself. So
and just on some of the pathways, there may be a choice to say, hey, I'm going to implement something in a downstream detail part of the pathway, and that can um, impact a small area, or it can be upstream where you may change something that then causes 8 different pathways to switch, including the one you're initially talking about going after. And those are clinical nuances because you can end up fixing something and breaking something at the same time. And if that's the case, sometimes you have to go further downstream to get more precisely on the part of the pathway that you're trying to work on at that moment, whether it's minerals coming in or blood or whatever.
I think that's kind of one of the things I like to highlight with the way that we approach things in the BornFree protocols, try to restore the resource pools, and rather than trying to exert direct influence in pathways, we try to then allow those pathways to regulate themselves. Um, it's tricky because in a number of situations, there can be some benefits from certain drug interventions. The challenge is understanding that they're exerting an artificial influence over that pathway. And so as the system, as the baseline is restored, a number of those interventions can become inappropriate and need to actually be withdrawn or removed from the system. Otherwise, you can't restore that homeostasis. So it's ultimately a balancing act, and it needs to be sort of carefully managed on the recovery journey. Is there anything else that we want to touch on here, or we keep going? Yeah, lactic acid metabolism. Well, I tell you what, we're gonna go into that in some detail in some of the biochem, but just touching on the symptomatic aspects of it. So a lot of people will, have felt like the burning, the muscle pain, the swelling of the hands and feet and things like that. And there might also be like a elevation of urinary output. These are all common symptoms for lactic acid elevation. And there are some biochemical issues around the acidemia and things that we'll be going into. Part of this is the post-exertional malaise, but also a lot of this lactic acid metabolism appears to be responsible for a lot of the progression of the mineral losses and the disease severity. So the pacing or the lack of pacing with mitochondrial dysfunction is something we'll be talking about in a little while.
And clinically, sometimes it may be helpful for clinicians to explain to their patients, or the other way around in discussions, that why is it that somebody's heart rate goes up 20 or 30 points by walking into the shower, essentially, or taking a shower, what seems like a small amount of energy use. One, taking a shower takes a bunch of energy, it turns out, but even just putting your feet over the side of the bed and standing up can make these changes happen. And at that point, if you're out of breath and your heart rate's really is going up, you are in an equivalent state of a finely tuned Olympic athlete, maybe at the end of their race. It's so they're both you're both in that place of exhaustion, but one person's getting it when they're just trying to get out of bed, and another person's getting it after running 20 miles at pace.
Mitochondrial fitness. So this is one of the efforts I've gone to in recent times to help try to better communicate the blocks of the cascade. Happily, this slide is broken up into individual blocks that we're going to go into. You don't have to stare at all now, but it's helpful just to see it all connected together, so that as we go over the individual blocks, you can kind of see how these things fit together.
And these blocks are the biochemical underpinnings driving the process of homeostasis, really, and the body getting out of that stuck at one end or the other of the teeter-totter back into the balance. And if you don't address the various blocks, you can't get in. The body can't take care of itself.
So this is the acetaldehyde issue. This is fermentation syndrome. Gut fermentation syndrome, bladder fermentation syndrome, are fairly well understood in the literature. From what I've seen, there's limited data on oral and nasal microbiome-derived acetaldehyde, but it is also another issue. We need to think about this in the same context of chronic alcoholism with a difference. In alcoholism, fair proportion of the alcohol actually gets absorbed into the bloodstream. With fermentation syndrome, it's mostly the acetaldehyde that makes it into the bloodstream without the alcohol. So the behavior biochemically is a little bit different, but it also means from a testing point of view, certain markers are not appropriate. Other markers will show it very clearly. The acetaldehyde presents a burden to the ALDH1 and ALDH2 enzymes, so it's a substrate excess, but it also creates a direct assault on the enzyme integrity itself. So elevations in acetaldehyde ultimately inhibit the ALDH1 and ALDH2 activity, but they also lead to a shift in the NAD to NADH balance, ultimately favoring elevation of NADH and low NAD. And this is largely in the mitochondria, but can also be in other enzymes in other parts of the cell. So when these enzymes are inhibited, or the kinetics basically allow the acetaldehyde to have a higher affinity for the enzyme, so that the substrates for the original pathways end up pooling, we then end up with an elevation of different toxic aldehydes. One of the ones I discussed before was dopal, which is the next metabolite of dopamine. But we see a number of other aldehydes. So like in the tryptophan metabolism, you've got 5-HIAL, so serotonin metabolite. There are a number of other unpleasant aldehydes that end up basically creating inflammation, damaging different cellular machinery. We have histamine being one of the, aldehyde generating pathways. And so we'll go into a little bit more detail in the histamine section about what that looks like and how the acetaldehyde directly influences both the histamine release, but also inhibits the histamine degradation pathway. And I think we have enough time to go into quite a bit of detail with that. We have,
We
as you
have
know
plenty
from...
of time, so take whatever time you want.
Oh, that's excellent. That's usually the opposite of my problem. So we know from alcoholism studies that we have a number of other issues being created by acetaldehyde. We have direct inhibition of the glucose uptake and glycolysis pathway. We have acetaldehyde related issues in a number of other pathways too. And the ALDH, just the last point there on this in this block, we have ALDH2 being directly responsible for regulating cholesterol biosynthesis. So one of the things that we see in commonality in aging and also with ME/CFS, COVID, whatever, is quite often elevated cholesterol. We also see elevated B6. That's a hot topic in Australia at the moment. We have the regulators looking to stamp out B6 supplements and things and slap warnings on things. But the aldehyde toxicity, if ALDH2 is inhibited, then you'll see elevation of cholesterol. You'll see potentially elevations of B6 in the serum. You might see elevations of beta carotene. You'll see a number of different aldehydes elevated. But yeah, the ALDH2 has a direct effect on HMG-CoA reductase. So if ALDH2 is inhibited, then HMG-CoA reductase activity is dysregulated, promoted. So you end up with an elevation of LDL from that mechanism alone. Anything you want to add to that?
I was just going to say, with in terms of the lipids, you clinically you can end up with a pattern of some unexpected triglyceride elevation too, I believe. And just because when you're doing standard labs, a lot of times the labs are normal, but if something's going from low to high normal, that could end up being a clue to look more deeply at some of these pathways.
Yeah, a lot of the ranges that are used in labs are not super helpful in actually picking up a lot of these things. The patterns that you need to look at will be subclinical, but you'll see them replicated across a number of other markers. So if you can see a pattern of aldehyde elevation, then yeah, that's a pretty good indicator that you've got other issues going on, and likely acetaldehyde elevation. There is actually a new marker for acetaldehyde, or not new, but new to me, just ToxDetect from Mosaic Diagnostics, that has a HEMA metabolite, which is a downstream metabolite of acetaldehyde. So, okay, so this was the endogenous morphine pathway that I was talking about before. So this is a simplified view of the dopamine metabolism and how this actually affects the endogenous morphine synthesis. One thing that I have highlighted in this slide is that a number of other pathogens have a direct influence on the dopamine homeostasis. And I think that this is going to be a very interesting topic in relation to other things like bipolar disorder and schizophrenia and some other interesting aberrant dopamine homeostasis. The there are I suppose T. gondii is probably one of the more interesting ones. I won't go into it today, but there is an image sitting on the BornFree protocol page, which actually highlights a lot of the alterations and what it actually does, and it is very, very interesting to study. Ultimately, though, what we can think about here is pressure on the synthesis pathway or dysregulation of the synthesis pathway versus inhibition at the ALDH, which then leads to the dopal accumulation. So, like without the ALDH inhibition, the extra dopamine is not necessarily going to lead to a significant increase in the morphine synthesis. So you may just have, more motivation. You might be more outgoing. It might actually be a really good experience. But as soon as the ALDH inhibition kicks in, then we end up with the elevations of salsolinol and THP, and that ultimately leads down the pathway to endogenous morphine. Not shown on that diagram, but it's a lot of CYP 2D6 and COMT activity down the pathway from salsolinol to endogenous morphine. And the CYP2D6 activity is actually expected to be upregulated as part of this cascade for other reasons. Like if the ALDH2 is being overdriven by acetaldehyde, one of the things that is upregulated is the cofactor for the CYP2D6, so that's NADPH. Anyway, going back to this diagram, the acetaldehyde is one of the most significant inhibitors of that ALDH1 and ALDH2 activity. But low NAD is another big issue, and there's low minerals, which is also created as part of the cascade. The ALDH enzyme requires a number of different divalent metals. Zinc is a significant one. Magnesium has a kind of positive and negative relationship with ALDH, depending on the levels of magnesium. It can either inhibit it or it can promote it. But zinc is a critical one. And part of the cascade of having acetaldehyde, and particularly when combined with acidemia or lactic acidemia, is that the zinc is likely to end up low over time. So this becomes a bit of a spiral and it becomes a loop in itself. We end up with a trap, which I'm going to go into in a little bit. Well, now.
Sorry, we can go stay back.
No, let's do that actually. I mean, unless you want to touch on that histamine
Nope,
angle, but we can do that in a little while. So this is a different representation of the NAD redox. And by redox, I mean the transition between the two different states of NAD. If we can see the name on the right, we have NADH, so that's an extra hydrogen atom. We have 2 extra electrons. That's the reduced state, and NAD plus, of course, is the oxidized state. So the NAD itself is switching back and forth between those two states. And what the diagram has there is the key enzymes inside the mitochondrial matrix, which is pushing the pressure from one side to the other. So without acetaldehyde, we have the pyruvate dehydrogenase complex. So that's the second one down. I don't know, John, if you can highlight that for me. So glycolysis itself, that's one of the generators of NADH. So it takes some of the NAD and converts it into NADH. Then we have 3 steps in the citric acid cycle, which are also going to be generating that NADH. So that's the isocitrate dehydrogenase, alpha-ketoglutarate dehydrogenase complex, and malate dehydrogenase. So it's basically the dehydrogenases inside the TCA cycle. Now, the other side of that, the primary lifter for converting the NADH back to NAD, so that what we call the NAD redox is NADH dehydrogenase, also known as complex 1. So complex 1 takes the H from the NADH, siphons off the electrons, and they get pushed down the electron transport chain to ultimately through to ATP synthase, returning NAD back to the pool So that's what's supposed to be, restoring most of the balance. However, the problem is that complex 1, or NADH dehydrogenase, is inhibited by a number of different things. So reactive oxygen species, reactive nitrogen species, innate immune signaling generally are going to be able to inhibit complex 1. And that basically means that the flux, the speed at which the NADH is converted back to NAD, is going to be decreased. And it also creates pressure for that NADH to then be going down other pathways or other enzymes to try to restore that balance. So that might be, for example, glutamate dehydrogenase. Whoops, still on the same slide. Sorry, John.
All right. Yep.
Whoop. Here we go. So glutamate dehydrogenase, which potentially leads you to excitotoxicity risk, depending on the P5P status. And then we also have NADP transhydrogenase. So under normal circumstances, these enzymes would still be working at a lower rate, and they would be relating to exertion, be getting more activity. So as soon as we end up with a little bit of oxidative stress, and that's from, like, say, doing a workout or intense activity of some description, we might end up with some of that flux sort of being pushed down through those other two enzymes, and that actually has a benefit towards immune and synthesis tasks. So a number of the enzymes relating to immune activity are things like NOS, nitric oxide synthase. We have NOx, so NADPH oxidase, and then we also have most of the synthesis tasks inside the body are being run by enzymes which have NADPH as a cofactor. So that might be hormone synthesis, it might be methylation, it can be a number of other pathways. But ultimately, this is all supposed to balance nicely. Now, if complex 1's inhibited, we already have, a redox issue. ALDH2, so if we have an elevation of that acetaldehyde, also acts like an exertion mimetic, like a TCA flux cycle mimetic. So it creates more a NADH or NAD-NADH imbalance. So it favors the NADH pool balance. So in some ways, you could say for a narrow window, it actually helps produce electrons, providing complex 1 is not inhibited. There is, a potential increase in energy. And some people may have noticed that if you don't have any CFS perhaps, or if you do, and you have a small amount of alcohol and suddenly you've got energy and everything feels great for a narrow window up until it doesn't. So this balance essentially between complex 1 and the flux through the other enzymes is the bottleneck. And so we can end up with a functional deficiency of NAD at the same time as an elevation of NADH, and you may then see excitotoxicity, and you may see, interestingly enough, depending on the status of NAD and some of the minerals and things like that, you might see, for example, like elevations of DHT if you're looking at hormone panels and things which are sensitive to NAD pH levels. So there are a number of ways that can be picked up without a direct measure, just looking at some of the metabolites. I don't know if there's anything else I probably need to touch on in here, but I suppose the loop, again, just the simplified version on the left-hand side where we have fermentation syndrome, chronic acetaldehyde, and we have this loop. So what's interesting is that the enzyme that's required to convert any of the precursors of NAD into NAD happens to be sensitive to cAMP-PKA. So that's that same pathway that we're talking about before, that flip-flop between the sympathetic overdrive and the opioid agonism and pathway, so cAMP suppression. So depending on the state, if you're flat out in fight or flight, then you are actually likely getting a reasonable amount of NAD synthesis at those points in time. But there will be other points in time where it's suppressed, and so it'll be sort of feast and famine rather than a steady stream of activity through that. So that can create like a total pool deficiency as well as a redox difficulty. So basically the elevations of NADH versus NAD. The combination of these two ends up with a total NAD deficiency. And that's something, again, that we see in ME/CFS and in the aging population, and we treat that as a normal, quote unquote, or at least a normalized thing. Something that has been added to the protocol in recent times is that last little item in the NAD to NADH, so exogenous redox support. So that's just down the bottom there. Thank you very much, John. So it's really interesting. Methylene blue is something that's been around for a very, very long time, but it is a little bit finicky to work with. The actual function that it's been added to the protocol for is this complex 1 replacement or support. So if you use a tiny, tiny, tiny dose of methylene blue, and this sits around about 0.05 milligrams, so it's 50 microgram ballpark, depending on the mitochondrial membrane potential. And there's a little bit of moving goalpost depending on the fitness of the mitochondria, but in that sort of ballpark, it has the ability to act as a dose-dependent complex 1 in many ways. The problem is that if you increase the dose even slightly above that, it does the opposite. It inhibits ALDH2 as well. So we can end up with missing out on that benefit by simply having a slightly too high dose. So most of the protocols that clinicians have been using for methylene blue might be for other reasons. Like it might be for like antimicrobial functions. It has been reported to be quite helpful in Lyme disease and a number of other infections. But for the mitochondrial benefit, it needs to be kept to this almost homeopathic dose to have that function, and anything slightly above that doesn't do that. As soon as the mitochondrial concentration gets above, I think it's roughly double what we're using it, then yeah, it's loses that benefit. John? Yeah. So cofactor depletion spiral. I'm going to go into that in the next slide in more detail, but there is essentially from chronic acetaldehyde, we end up with a spiraling deficiency of basically all of the active coenzymes. I'll go into that actually. John, do you want to jump straight into the next slide? Because I think it probably is a little bit clearer. So I'm going to start from the bottom and just with the red boxes for a second. So we have retinoic acid, so that's active vitamin A, also known as tretinoin, the acne medication. So retinoic acid has a number of different functions for energy metabolism, highly underappreciated. However, it's also sensitive to the NAD status. So what we just talked about there a moment ago with the NAD redox, in that situation, we end up with low active retinoic vitamin A. I won't go into the low NAD NADH. I just did in quite some detail. A lot of the other low active coenzymes are going to relate to low zinc status. I'm going to go into the low zinc in a lot more detail shortly, but the actual outcome of having low zinc in this state, other than B1 and some of the oxidative stress, which have a separate problem created by acetaldehyde, the low zinc is amazingly problematic in the system. So all of the active, or almost all of the active coenzymes require zinc for their synthesis pathway. And some of these are dependent on each other. So you'll see, for example, if you look at the low FMN and FAD, which is just below John's mouse pointer there, that's the riboflavin metabolite. So with low active riboflavin, we then have difficulties with methylation, for example. We'll have difficulties with P5P metabolism. We end up with elevations of B12, for example, in the serum. So one of the things that pops up commonly, clinicians will see elevated B12, and usually they'll think that's relating to supplements and things like that, when the reality is that it's actually an indicator for generally low zinc and low B2. And the mechanisms that create that are described in this diagram. One of the other challenges there is, of course, the low coenzyme A. That's a few over to the left there, John. And that can come downstream of low intracellular P5P. I haven't included a slide today that goes into the finer details of the P5P metabolism, but the deficiencies of zinc and magnesium are highlighted, well, at least the zinc part here, in this diagram. So low zinc and low magnesium have a significant impact on the ability to maintain sufficiency of active B vitamins and other vitamins. B1 or thiamine pyrophosphate, which is the active version, is really interesting. So that has a separate challenge. So it's not purely zinc related. In fact, it's not really zinc related. Um, the acetaldehyde itself will form an adduct with the thiamine. So what that means is you end up with low levels of active B1 at the same time as if you are measuring the B1 in the blood, it may appear to be normal sometimes. And it depends on the assay that's being used. The acetaldehyde also happens to inhibit TPK1, which is the one that actually converts the other forms of B1 into thiamine pyrophosphate. So it kind of gets hit in two places. There are protocols online. I think it was Elliot Overton, I think, is one of the thiamine guy, like the thiamine megadoses. Um, One of the things that you can do as part of this cascade and the intervention is to actually support that. Like you're fixing up the zinc is not going to solve necessarily, the acetaldehyde excess issues by itself. The methylene blue intervention, the protocol to fix up some of the NAD metabolism is going to help reduce the net acetaldehyde and will have a knock-on effect to thiamine availability and things. But one of the things you can do as part of the intervention is just to flood the system with additional thiamine. So we can use that to actually mop up some of the acetaldehyde. But of course, any of these different things is going to be potentially inducing withdrawal symptoms as well. What else we could touch on? Oh, okay. So CoQ10. We were talking about the electron transport chain before. So ubiquinone and ubiquinol are kind of the redox pair for it's like a liquid electron transport chain. And as you can see in this diagram, a number of the active coenzymes are required for part of the pathway that produces CoQ10. Iron is another important thing. So we can infer by the iron status, and we can infer by the status of the active vitamins, how much CoQ10 is potentially going to be produced, and if that's appropriate for the electron transport chain sort of functionality. So in the protocol, we like many of the other vitamins and metabolites, will actually be supporting that directly. Oxidative stress. Look, this doesn't go into enough detail for the issues with oxidative stress, but it just touches on the fact that the acetaldehyde itself is a reactive oxygen species generator. And look, it'll do that in multiple ways. Acetaldehyde happens to activate nitric oxide synthase and NADPH oxidase directly, and xanthine oxidase. And these are the three enzymes which are used as part of the innate immune response pathway. So simply having acetaldehyde in the system chronically is enough to ramp up oxidative stress all by itself, separate to having any kind of ongoing immune response. So there are other pathways too, but just not included in this diagram. John, anything you wanted to touch on here?
Just a number of people end up having the MTHFR variant, and so having trouble methylating with methylation, and that you could see that ends up adding another layer to this problem clinically, and where you've got to try to get more easily accessible methyl donors.
Yeah. In the protocol we use, I mean, look, there's actually multiple steps to that folate issue. You'll see downstream also of the thiamine, so the thiamine pyrophosphate, that and the zinc are both required for two of the folate transporters. So that's SLC19A1 and FolH1. So there are ultimately, look, there's not a lot to do as far as the MTHFR mutation. I mean, I've got it. I don't have, without ME/CFS, without metabolic stress, I don't have to do anything in my daily life to accommodate it. It's something that presents no metabolic challenge to my health and fitness at all. In a state of metabolic stress with chronic innate immune response and depleted minerals and things like that, I might see some personality around that mutation. In the context of remediation, I think the take home is going to be that if you wanted to put additional support in place, you'd be using the methylated forms of folate, so 5-MTHF, or you can sidestep the transporter issue and DHF by using folinic acid. The problem that you've got, of course, is, and you'll probably find the audience has seen this, there'll be some people that are initially super sensitive to using the methylated forms. And in part, that's because ultimately the whole system's so far out of homeostasis. You suddenly turn on the tap in methylation, you add in some 5-methylfolate, and suddenly you get a burst of SAMe, and then you're now getting like a burst of adrenaline, and you're pushing into that sympathetic overdrive again and everything else. So it's something that has to be done in a severe patient very carefully, slowly bringing up all of these things in a balanced way. And somebody might say, oh, well, hey, we can just, add some zinc in there and slowly bring that up, and that's going to solve a lot of that. Well, apart from obviously the oxidative stress and the B1. Yeah, that is actually true. But you're going to have difficulties in getting the zinc up while you're still dealing with the chronic acetaldehyde. So
And
you would have to go upstream. Yeah.
I said I'll add there something that we've discussed a lot of times too, which is the creatine synthesis taking 40% of methylation resources. So that part of the protocol with the supplementation of creatine is also helping the methylation processes.
Yeah, I think who's at the moment? Somebody else is on the creatine bandwagon. I think it's Rhonda Kirkpatrick has been talking about 20 grams a day as being helpful in aging population. I mean, ultimately, fix the pathways and these things are not necessary. But while people are dealing with these impairments and not understanding what's actually driving that, yeah, adequately supporting the pathways sometimes means putting in, exogenous and sometimes large amounts of the amino acids that are produced downstream of some of these synthesis pathways. So yeah,
And
thank
it
you.
just as another example of sort of the interactions and interplay, if you're sitting in a place where your energy production is glycolysis, you've got more lactate, you create acidemia, and then all of a sudden you're getting rid of zinc even faster because of the way the kidneys work. And so
Yep.
there are just so many places where you start filling up the bucket in a certain way, and that in itself can even cause a bigger hole in the bucket downstream.
Well, this is the problem. You start getting some of these pathways working. So somebody who's got low phosphorus, example, and low magnesium, you start ramping up the phosphorus and magnesium intake, restoring the front end of the glycolysis pathway, and now you've suddenly got more lactic acid to deal with, and now you can then spiral the zinc and everything else. So it's really got to be a careful balance, and that's also where the pacing and some of the other aspects need to come into play.
And the clinical push to sometimes go slowly, and if this took months and years to break down, another week or 2 weeks or 3 weeks on a process of trying to make sure that you're not inducing a crash can be really helpful to that maintenance.
Yeah. I mean, in time, I think we'll get better and better with this process, but it's as it stands now, there's no rush. Like, just do things, listen to the body, and take feedback from the data. Do things carefully. So this is another recent diagram, and this really does try to highlight that zinc deficiency and renal wasting that we're just talking about, but it does also incorporate a number of the other aspects that we were also talking about before. So yeah, the issue with the zinc loss, we can see that there at the top. If we have the glycolytic shift, so if we end up with, for any of the reasons, prolyl hydroxylase inhibition, HIF1 alpha stabilization, they essentially, the prolyl hydroxylases act like fault sensors for the mitochondria. So they're sensitive to hypoxia. That's why the protein itself is known as hypoxia-inducible factors. The prolyl hydroxylases sense for a number of different full conditions. They sense for hypoxia. They sense for oxidative stress. So prolyl hydroxylases, they need vitamin C as a cofactor, sorbic acid. They need iron for part of that sort of redox. And they also have zinc to stabilize it. And interestingly enough, silicon acts as a potential another replacement for iron. And I think there's a logic to that in the context of the iron being kicked out of the cells, by the inflammatory cascade during the immune response. Silicon appears to be part of the resilience against that tripping the hypoxia sensor during the immune response. So silicon deficiency potentially leaves you more open to being, in lactic acid, like lactic acidemia. So it's something that I think is underappreciated in sepsis and septicemia.
And people will hear the term pseudohypoxia, and this is so you have direct hypoxia where the oxygen is low, and that stabilizes HIF1. But the pseudohypoxia is some of what's getting discussed here too. So you can end up with the same biochemical response coming from two different directions.
Well, it is, and look, it's not really being discussed today, or we could maybe bring it up in questions or something. But I mean, if you end up in ketosis and you've got low NAD, you can expect the succinate levels to be elevated. You can expect that to inhibit the prolyl hydroxylases as well, and you can see that sometimes in the organic acid test data as well. So you'll see, the beta hydroxybutyrate's elevated. You'll see succinate levels elevated. And then even if succinate dehydrogenase is working, there's still enough there to trigger the lactic acid threshold. And then downstream of that, you'll see all of the markers. So you may or may not see lactic acid being elevated. You'll see, however, the oxalate markers, or particularly oxalic acid, elevated. So these are all good clinical indicators that you have this metabolism or this cascade active at that time. So the loop being created here, though, is the zinc deficiency. So the acetaldehyde and the exertion, while there is mitochondrial dysfunction, leads to the renal wasting. And so it's all of the electrolytes. We end up with the phosphate, the zinc as well, which is not an electrolyte, the magnesium, calcium, sodium, potassium. I mean, we know all of this from diabetic ketoacidosis and from acidemia studies. The hyperoxaluria is triggered as part of that cascade. So when lactate dehydrogenase is elevated, if there is simultaneously low P5P, there's competition at glyoxylate. It can either go back to becoming glycine, which helps with the collagen synthesis. But if P5P is low, then the bias is favored towards oxalate synthesis. So oxalates create a whole cascade of misery of their own, but ultimately you can use that as an indicator for the anaerobic glycolysis shift. Other things that are highlighted, sorry, on that diagram, the chronic reactivation of the herpes viruses. So that is, interestingly enough, the anaerobic glycolysis, the shift towards HIF1 alpha stabilization also happens to be a trigger for reactivation of latent herpes viruses. So if the cells are in that state and they happen to be infected, it's quite possible that they're also going to trigger a lytic reactivation. I don't know if there's anything else that I probably need to highlight in here other than the competition around the early discussion around the hepcidin and divalent metal transporter 1 of ferroportin. That's over on the left-hand side. So some of the cytokines which are elevated by that lactic acidemia also happen to be one of the major signals for blocking and sequestering the minerals. And one might say that perhaps that's a protective mechanism against them being lost in the renal excretion, but it's hard to say. All I can say is that does have a direct effect of essentially limiting the intracellular availability of those minerals for the other pathways at that time. I mean, the take home from this is, pacing is critical up until the point that you can resolve that mitochondrial dysfunction. And the lactic acid and the oxalates are a really good, downstream mechanism of assessing the, I suppose, the appropriateness of exertion. So if your data shows that you have huge amounts of oxalates, then yeah, like exertion is going to drive you into the downward spiral. The zinc losses and everything else. You should be resting at that point until at least you can get the zinc and the other levels up. Once you can get your head above water, then the doors, it opens up towards exertion again.
Just
John,
noting the as well as the acids reactivating the latent viruses, that this whole process of getting out of balance can change the availability of the interferons, which can help to squash the viral load. So there's you can have a, hey, the body doesn't have the ability to keep it down, or the body's creating an environment that makes it pop up, and both of those play together.
Yeah, the cortisol dysregulation is really, really interesting. I mean, cortisol is such an important hormone. It's not just for immune suppression. It does so many things for regulating the catabolic pathways and the energy metabolism. And we have some clinicians that will see a benefit by giving low doses of cortisone or hydrocortisone to patients to try to normalize the morning cortisol to give more energy. Um, it's something that can be helpful. Ultimately, you'll normally find, depending on the status of the minerals and some of the other things, that the cortisol levels that you should see in the morning are peaking in the middle of the night. So it's like having jet lag. It's not necessarily going to be beneficial long term to try to boost the morning cortisol directly, rather than actually try to instigate a shift of the diurnal cycle back to the normal, the normal spikes. Uh, yeah. Anything else there, John, that you wanted
No, I
to?
don't think so. But this is if people do get the slides, this is a really important one for sort of thinking through all the different moving parts. And down here in the blue box, there's a sort of the impact of what happens with the different changes in some of the minerals and other components.
Yeah, and those are just some of the highlights. I mean, the impact of the mineral deficiencies is, yeah, there's about 2,600 odd metalloproteins. There's quite an impact.
One quick question that is in there that fits in there, Josh, is the type of magnesium that you're speaking about when you're talking about fitting it into the pathways.
So Mg2 plus normally, but do you mean as far as the intake or the?
I
The
think it's
intake. The
yeah,
intake
whether
was
it's
the question. Yeah.
Oh, okay. Well, I mean, magnesium is magnesium. At the end of the day, if it's, whatever form it's in is less relevant than the total amount, and the speed of absorption. So one of the challenges is that the electrolytes are fairly tightly regulated. If you go and take, let's say that, you understand that you might need 500 milligrams of elemental magnesium in a day, and if you go and take that 500 milligrams all in one dose, you may have diarrhea. The body might see the elevation of the magnesium in the circulation, and the kidneys will essentially take that as a cue to dump it. So the amount that actually gets retained is only a small fraction of that. On the other hand, if you were to drip feed it across the day, and we've had multiple ways of doing that, there's something in the protocol where we're using an electrolyte sipper. Other people will take that sipper and pour that into glasses and add a water to dilute it further and do that sort of 8 or 9 times a day. Small amounts across the day does a lot better for improving the magnesium absorption and retention than large doses. That said, there are a number of other things that are going to affect magnesium. We talked about the acidemia and what happens with the kidneys. The other thing that is really critical to that is the boron status. So boron deficiency is going to allow for excessive amounts of calcium magnesium excretion as well. So resolving a boron deficiency is going to be a key part of fixing the magnesium status. There are other things too that potentially relate to it. A calcium deficiency is also going to create a problem for magnesium levels. You can we could go into the weeds of that if you want. But a lot of the intracellular magnesium is going to come from swapping with calcium. You've got the ATPases and things like that. It depends on the tissues and it depends on a number of the things. Rule of thumb, though, yeah, drip feed the magnesium, fix any boron deficiency, and stay out of lactic acidemia is basically the ways to get the magnesium and the other electrolyte levels up.
Right.
The protocol is using multiple forms. I think we've got magnesium aspartate and a magnesium gel. The aspartate was largely chosen just to help with the aspartate levels. There's a separate issue that creates low aspartate, which is downstream of the microbiome dysbiosis and the cuine synthesis pathway, amongst other things. Well, we started talking about this before. So this is zinc excretion and acetaldehyde. So acetaldehyde essentially liberates the zinc, and then the acidemia pushes it out the kidneys. So it acts as a multiplier. So the combination of these two things together is a large, well, creates a large net decrease in the systemic zinc levels. And one of the things that is challenging is that because of the state of inflammation and the mineral transporters and everything else that's going on, even putting in large amounts of zinc into the system, even if you get it past the transporters and things initially, is still going to be a struggle, even with zinc ionophores and everything else, unless you sort out that acidemia. It's really challenging, but that has to be done. The other side of this is the albumin. I mean, you can monitor the albumin levels, and I'm sure the clinicians will be. And if you start seeing the albumin levels getting lower and lower, you can see that this is going to be getting more and more problematic. So it's something that ultimately pacing, so some rest is going to be helpful for, but also dealing with the mitochondrial dysfunction directly by supporting the cofactors which are low. I mean, B1 is going to be a problem, and sorry, and any hypoxia, of course. B1, the B2 and B3, you've got the citric acid cycle cofactors, so like your NAD and your FAD. FAD for succinate dehydrogenase, NAD for, well, pyruvate dehydrogenase complex, isocitrate dehydrogenase, alpha ketoglutarate dehydrogenase, malate dehydrogenase. Magnesium, of course, also being useful for a number of the reactions in the pathway. And of course, you've got the iron sulfur clusters as well as part of the electron transport chain. So these things and oxidative stress need to be addressed to kind of get rid of that lactic acidemia problem. Um, Anything you want to add in there, John? This is all part of the same.
No, I think we can go forward. Yeah.
Yeah. Bone buffering, osteoporosis, osteopenia. Okay, so part of the pH imbalance in acidemia is going to be compensated for by dissolving bone to try to compensate, and that's where it ends up in the through going through the kidneys as well. So this is part of again that compensation, but ultimately part of the spiral. So anything that we can do to stay out of that state of acidemia is going to have a benefit towards restoring the electrolyte status and ultimately, improving baseline metabolism.
And if you presumably, if you look at geriatric issues and bone loss, that some of this plays in as longevity as well.
Yeah, absolutely.
And so
Yeah.
and I think you touched on it as a theme at the beginning, but if you really take care of this metabolism along the way, you may, if and fix it, you may be doing things to give more resilience as time goes on too. Or if somebody's healthy and goes through some of these same processes in a modified fashion, it may help again to lay down more raw materials.
Well, I don't want to say too much, but what I have observed is that if you treat an elderly person in the same way that you would treat an ME/CFS patient, then they respond in kind.
Yeah.
So from a longevity angle, yeah, I think it would be something very, very interesting to formally study. Is looking at aging as CFS directly.
Great. And then there's
Histamine.
histamine.
The love-hate relationship with histamine. So histamine is really, really important. It's only in probably the last year that I think it's been really appreciated that histamine has a role, an important role, in the liver glycogen and muscle glycogen homeostasis. And the problem we've got is that histamine is highly dysregulated by the aldehyde metabolism and highly dysregulated by the other deficiencies. And importantly, the acetaldehyde itself happens to act as a trigger to degranulate mast cells. So it raises the overall histamine levels. So it triggers the histamine release, it inhibits the histamine degradation, So the basal tone, if you like, for histamine is elevated. And that has a huge knock-on effect for glycogen. It has a knock-on effect for dopamine homeostasis as well. So tyrosine hydroxylase has a direct input from histamine and different receptors. And there's difference between spikes of histamine releasing more dopamine in different parts of the brain, and then chronic histamine potentially lowering overall tone as well. So glycogen and liver glycogen controls a significant portion of the cascade relating to things like POTS and PEM. So having elevated levels of histamine downstream of any of the rest of the cascade is going to drive you more and more into like a crash state as well. So anything that you can do to get out of sympathetic overdrive, lower the histamine tone, or restore the histamine tone is going to have a net benefit on liver glycogen, and then allow you to sort of move back into this, anabolic state, and allow the repair processes to actually run. We can flick through to, yeah, this slide. So this, I think, is a fairly clean way to look at this. So starting from the top, we have the overgrowth of the acetaldehyde producing microbes. We then end up with the elevated acetaldehyde. That can directly affect the epithelial barrier. So if we go down to the left, which then allows other antigens, foreign proteins, to get through the barrier, which then can trigger not just the immune response, but also the mast cell degranulation and histamine release, which then has a relationship with the hormone levels. So estradiol is going to promote the mast cell degranulation. Androgens are going to inhibit that somewhat. And then, yeah, we then have the acetaldehyde directly inhibiting the ALDH function, which then allows what I was mentioning before, a net elevation in histamine. So then we have if we go across to the right, we have histamine increase, that one. So that then gives us sensitivity to environmental triggers and food and various other things. So what should be tiny little triggers of histamine then turn into, the straw that broke the camel's back. You then end up with reactivity to anything and everything, and smells, and the mycotoxins in the environment, and various other things that are going to create a very unpleasant day. But what that also means is the exercise response is now going to be aberrant. So what is supposed to happen post exertion is that the just going down from histamine release there, John. So right and down, yeah, beautiful. So histamine, the H1 receptor, what happens is that the macrophages outside the muscles ultimately trigger IL-6. IL-6 then activates STAT3, and then that then upregulates GLUT4 and glycogen synthase. So what that does is it primes the muscle cells to be insulin sensitive, and to take any circulating glucose, suck it up into the muscle cells, and convert that into glycogen. Now, simultaneously, what happens is that H1 and H2 on cells in the liver, so that's up to the right there, John, also trigger the glycogenolysis and gluconeogenesis. So what happens is that in effect, it's redistributing the liver glycogen into the muscles. So great, that makes sense in a normal healthy state. It's a signaling molecule to move the glycogen around. However, if the background histamine levels are up, that means that we're constantly driving the liver glycogen into the muscle cells. And eventually, because of that and the other cAMP dysregulation, everything else, we're going to end up in a situation where we keep depleting the liver glycogen. The tank is always running on empty, and then we've got ultimately an over-reliance on the other catabolic energy pathways. So we have postural orthostatic tachycardia syndrome and post-exertional malaise and everything else.
And then
So it's
another piece that can come out of this. So as you increase the pressure on the mast cells and the degranulation, you end up in the process, especially along the edges of the endothelium, you can end up with an increase in von Willebrand's factor, and then you end up with increases in the intrinsic clotting cascade, and then that can circle around to block more of the flow, and blocked blood flow stabilizes that HIF1, which reinforces this process. So they're mechanical loops that get in the way, as well as biochemical loops that get in the way.
That's right. Oh, and you can see that other, pathway there from the ROS to BH4 oxidation, eNOS uncoupling, superoxides, blah, 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 complex 1 inhibition, low NAD, and then ALDH inhibition. So that was just that other pathway there. So
And
it's
nitric oxide in the whole relaxing of
vascular
blood
clearance.
vessels, and I
Yeah.
mean all these things play off. It's wild how they all interact.
But it's nice when you can see it laid out like this, you can then understand what's going on. It takes a lot of the uncertainty out of it, and it gives you a clear direction on how you intervene. And this is the liver glycogen. So what should be happening and what is happening are two very different things. So we have, as I was saying, an abundance or overabundance of sympathetic drive. We have essentially the sensitivity in the cAMP-PKA pathway. So we have CREB essentially taking light signals and turning it into large signals. So the beta oxidation becomes hypersensitive, but also overly used. Yeah, we end up basically with this hyperglycemia triggers, ultimately a functional glycogen storage disease. I don't know if there's anything more I probably need to touch on from that, because I think we've covered it pretty well. Retinoid metabolism, I haven't included a diagram. I didn't think we were going to get time to go through it, but we could. Active vitamin A is critical for immune functions, for energy metabolism, for stem cell differentiation, for Treg, for a number of different things. So the acetaldehyde and low NAD cascade ultimately leads to an insufficiency of the retinoic acid forms. And yeah, it's really interesting. There was a couple of studies recently showing that ALDH1A1 and retinoic acid was responsible for limb regeneration in axolotls, and I think there was a rat here recently and a few other things. I think there's going to be some exciting developments as far as regeneration of tissues, probably over the next few years, being discovered downstream of that mechanism. But for now, it's just nice to be able to restore the normal homeostasis to that pathway and see tissue repair and energy metabolism being restored, and barrier function being one of the key ones. I mean, we see it and we've known about it as far as, acne for many, many, many years. And it baffles me. It absolutely baffles me that active vitamin A could be patented and turned into a drug for acne and restricted instead of being sold as a vitamin supplement, which is what it is. Unlike the other forms of vitamin A, which can be overloaded, so retinol, it's fatty, it can be stored, or you've got the, retinol palmitate. The active form doesn't. It's in and out, much like the other B vitamins. It has no real toxicity. Well, within a certain range. There's never, never say never. Even water can be toxic in too high amounts. But it has applications. There's all sorts of interesting things for cancer research. It's a very exciting area. So having low retinoic acid has a fairly significant impact on the ability to maintain the system in diverse conditions or adverse conditions. Right. Okay. So this part or this block is looking at a number of the alterations downstream of the innate immune response. So without showing the pathway on the screen, we talk about IDO and TDO, so IDO1 and TDO. So that is essentially taking tryptophan, which is a precursor to serotonin, but also to kynurenine, and favoring the use of that tryptophan for the kynurenine pathway, which sits just upstream of NAD synthesis. So in effect, what we would think is that when complex 1 perhaps is inhibited, when the innate immune response is up, we're trying to borrow some of that tryptophan that should be, normally going towards serotonin, and we're trying to maintain the NAD pool, which makes sense because NAD is the primary currency for a lot of the immune response towards the reactive oxygen species generation. A lot of the alterations are revolving NAD as the currency for a lot of these pathways. Unfortunately, the downstream effect of that means is that you might have more emotional dysregulation while the immune response is activated. And that might be, sadness and grief and 5 a.m., sort of being rattled by various skeletons in the closet and things, but it's mechanistic to the immune response trying to keep you alive against these pathogens.
And then, did you want to just touch on within the microbiome and short chain fatty acids as some of the raw material in the tryptophan pathway? We talk about swapping out some of the microbiome as changing the building blocks coming in, and this is where you see the impact. You see the impact of that.
Well, you do, and look at we go back then into toxins. So interestingly enough, a lot of the tryptophan is coming from the gut microbiome, and the gut microbiome, which is the shikimate pathway, is inhibited by glyphosate. So if you happen to have a high daily value of glyphosate in your wheat products, then yeah, it's insidious. You find glyphosate even in breast milk. You can expect that the microbiome is going to have difficulty keeping up with the sufficiency of tryptophan synthesis for your needs. And the dietary intakes of tryptophan, particularly if you're on a restricted diet for other reasons, are likely not going to be enough to maintain both of these pathways. So it becomes a struggle. There have been some papers recently talking about these alterations in long COVID and various other states, but I think it's a more complex problem that you're not going to solve completely without actually fixing some of the problems with the food chain as well.
Great.
But yeah, again, the layered effect. I don't know if there's too much else in that block. Yeah. So energy failure. All right. So we've talked about many of these already today. So the cAMP-PKA, when it's down, we have inhibited NMNAT, so we end up with low NAD synthesis. We then have the tyrosine hydroxylase, it's TH there, the low dopamine. It's the regulation basically for the opioid synthesis pathway. So that should self-regulate under normal conditions. Unfortunately, due to the dysregulation, that ends up being not the case. We have the glycolysis. So if we have problems with the glucose uptake, low biotin, low magnesium, low chromium, vanadium, elevated cholesterols, acetaldehyd, all the things that affect the front end of the glucose uptake and glycolysis pathway. Then we can end up with low, what is it, the pentose phosphate pathway and some of the other pathways downstream of glycolysis. And that's going to be affecting a number of different things. So nucleotide synthesis, absolutely. One thing that's not mentioned there, but it might as well, it's a popular topic in the younger male and I guess the older male population, and also in the female population, is alopecia, so hair loss. And you've probably seen, or may not have seen, there's a certain molecule called deoxyribose, which comes off that pathway, and has been discovered in recent years to have a similar effect on restoring hair as minoxidil. So it's highly suggestive, and I've seen anecdotes from people doing the protocol that restoring the glycolysis pathway is an instrumental part of actually recovering from hair fall and hair loss. Other things that are in there, I don't know that there's probably too much else that we haven't already really touched on there. No, that's, I think, well covered. So the output states. So we're bear with me. We're reaching nearly the feedback loop to the end of this, this diagram. So the output states, we end up with a hyperactive immune system. We've got cytokine excess. We've ended up with poor tone in the neurotransmitters, the catecholamines. So we end up with effectively low dopamine. Every time it goes high, then it spikes morphine, and then dopamine goes back low again. We end up with low norepinephrine, elevated epinephrine. We end up with low 5-hydroxytryptophan, and potentially low gabatone via the low P5P, potentially at the same time as elevated glutamate. We also have further alterations from the acetaldehyde directly on GABA and glutamate, but that's not mentioned in there directly. We have redox failure in a number of places. We have elevated reactive oxygen species and reactive nitrogen species. We have mitochondrial hypometabolism, so dysfunction. We have the anaerobic glycolysis. We've ended up with impaired barrier function, low retinoic acid, everything else, and the acetaldehyde directly affecting a lot of the metabolism relating to the barrier function. And then we have, the unfortunately really unpleasant symptoms. So we end up with the fatigue, we have the sensory overload, light and sound sensitivity, we have Some of the other, alterations that lead to a very kind of shut in, shut down experience, which is highly unpleasant to be in, having been in that one myself. And this is all mechanistic to this cascade, and it is all reversible, as we've seen time and time again. So the mineral depletion, of course, via the hepcidin cascade and not mentioned there, but the lactic acidemia and the acetaldehyde as well. Feedback loops, again, just reiterating, the same. These are the key ones. So if nothing else from this series or this slide that you take home, these are the key ones that need to be focused on. Addressing these will have a significant improvement on the baseline.
Fantastic. So that takes us full circle around the different blocks and what's going on, the complex interactions between these pathways. And so now what we're going to do is zoom out a little bit in terms of the clinical impact of it. And so sort of summarizing the idea of there's the yin and yang between breakdown and buildup. And go ahead with this, Josh.
Yeah, so anabolic and catabolic. So we have on one side, if we were to look at this from the quote unquote, fitness and bodybuilder side of things, they talk about anabolic hormones versus catabolic hormones. So like the primary sex hormones versus cortisol being the catabolic hormones. But at a more nuanced and granular level, we're talking about this at the cellular level, and ultimately how the cells are, there can be a mix of different tasks going on, but we're either recycling and breaking things down, or we're building things up, and normally that's done in a balance. And unfortunately, with the signaling cascade that's set up, is not enough of the anabolic processes being carried out. There's resource shortages. These things can't work. The cells are in crisis mode, so they're just trying to keep the plate spinning and trying to keep things working. And they're borrowing from every other pathway that's less essential to try to keep these things working. But ultimately, the processes around tissue maintenance, collagen synthesis, things like that are going to be quite noticeable over time while stuck in this state.
And if you see the same process happens in a localized level in wounds, and so as you end up sometimes as people age or in some of the conditions that we're describing, you end up with impaired blood flow to limbs, and so then you have wounds that have trouble healing, or you have extra venous blood, and so you get venous pressure ulcers or venous ulcers and so on. And that what happens is they get stuck in that breakdown state where normally that acute state is, hey, I skinned my knee, and so now the body's going to rev up a whole bunch of activities to scoop out the broken pieces, and people call it autophagy, and you break down some of the cells and the apoptosis and so on, but pull it all out, and then that sets the stage to put the new building materials in. But if you get stuck in that inflammatory loop, then the building materials can't make it go. Or if you've got too much lymph flow, you get fluids sort of drowning out that process. And that happens at a micro level, but you can see it at in a wound, but you can see it in other parts. And if you look clinically, sometimes people will do senolytics and they'll all of a sudden a week or two later get breakdown in, they might see what looks like cystic acne in a lymphatic flow area. And what you're really seeing is this a whole bunch of tissues coming down. And if the body can deal with that extra load, then the new good stuff comes in and it builds it. But if it can't, then that becomes an open festering area that takes a while to heal.
And now we get back to the nervous system adaptations. So we touched on this a little bit in the beginning, and again, highlighting that this is not something that is, and it's a really difficult topic to talk about when, unfortunately, we have a patient population that's been gaslit and traumatized by hopefully well-meaning clinicians that have tried to psychologize the disease. And it's very clear from the abundance of all the systems that are affected and the data and everything else that there's a lot more going on than anxiety. So that said, what we do have is, as we've seen with the, what happens with the opioid synthesis, and what we know from even just chronic opioid use, we end up with that state basically being set up where we have a predisposition towards fight or flight. We have metabolic crises being created, which is initiating the fight or flight. We then have the gut dysbiosis or the other microbiome dysbiosis creating the morphine pathway. We have all of these things going on, and we have a nervous system that's learning via electrical signals and pain signaling and everything else. And we have somebody that is basically being traumatized every day by this, quote unquote life that they're, experiencing. And so it learns to try to keep you safe from these pains and these danger signals and things. And so it's perfectly normal for that nervous system to then be, hypervigilant or become hypervigilant, to be looking out for the next threat to keep you safe from that threat. And so part of the repair process, and it is a critical piece, is that once you've actually dealt with enough of the real crises going on, is to make sure that the nervous system is then calmed down and soothed so it can hand back the roles and responsibilities back to the other systems. And it's just difficult because if it's not, if you're stuck in that hypervigilant state, even after resolving, the metabolic dysfunctions and everything else, then you're going to have difficulty maintaining liver glycogen. Then you're going to have problems with the hyperactive nervous system. It's something that has to be worked on. We have, for example, stellate ganglion blocks being quite successful for some patients. Again, not until you've resolved the original metabolic crises in the first place. Otherwise, the crash state that was being created, that the hyperadrenergic signaling is now kind of protecting you from, you've now just removed that adaptation or that compensation. So you now end up back in the crash state from the stellate ganglion block. So there are a number of different ways that can be, intervened. At the end of the day, the nervous system takes electrical feedback from a number of different inputs, sensory inputs and other things, and can use those patterns to either detect a threat or to be soothed or, ultimately reprogrammed. And this is something that needs to happen as part of the recovery process. What that is and how you go about that, there can be multiple different ways to interact with the nervous system. It can be that you could do stellate ganglion blocks, and then, once the nervous system is seen, oh, actually, it's all right, I can exist, I'm okay, there is no threat, it can adapt and do that by itself just by repeat exposure. It can be that you do various different programs to reprogram the nervous system. There are a number of different systems and programs that are, available that will have a certain level of success. I've mentioned some of those in the protocol. Ultimately, I don't have a particular recommendation myself as to which way I would go about it. But there are, multiple avenues that can be pursued, but it is something that needs to be addressed. It needs to be recognized that that is something that has also lost homeostasis, much like the other systems.
And some of the vagus nerve stimulation is a direct pressure on the parasympathetic sympathetic balance to say, hey, put more parasympathetic in and quiet things down. But I think a critical take home in the clinical discussions is that this is not a psychologic condition, and there are very meaningful biochemical changes going on that change the fundamental energy abilities and makeup and raw material that are driven by these loops of chronic inflammation. And one of the things as a side effect of those perturbed loops is this wired and tired, that sympathetic overdrive. And so that's not the cause, that's the response. You've got to get out at the root to start getting rid of the overall grounding piece of this. And I think that's the challenge that we see clinically. People say, oh, no, all the lab values are fine, and so there must not be anything wrong. It's all in your head. It's completely false. The lab values are not the lab values looking at these metabolic changes typically. And
you use the right test, you'll see what's happening at the metabolism. But I mean, ultimately, you do the work, you resolve the deficiencies, you clear out the dysbiosis, you deal with the infections enough. And then it's like, having been to war, you were talking about the soldiers with PTSD coming back from war. It's the same situation. Like, the body's been at war. you then need to come back and then go through a healing process, and allow the nervous system to realize that it's not at war anymore, and restore that homeostasis again.
So then
So
that kind of brings us around to the protocol itself, and what are the steps, what are the timing of it, how does it work, and why don't you go forward here, Josh? Or
look, I think the timeline is indicative, and the problem is that it's a very personalized journey. So where I put the duration there of at least 2 weeks, we have people where they've come in with, a feeding tube status or worse. Um, and to get from that state to the next state, it's going to take that person a lot longer. You're going to go through very, very gentle repletion. You're going to baby steps, trying to bring the system up in a very controlled manner to avoid a lot of the rush symptoms of just turning on all the taps in all the right places and then sending the person to hell and back. It's possible you could do it that way, but I certainly wouldn't want to be the patient. Um, so that being the case, the pace needs to be set by the patient and the tolerance, and that ultimately is, the guidance is going to come. It's going to be driven by the patient. Sometimes there can be, again, we talked about, because of what's happened in the past, there might need to be, gentle guidance and hand holding. And I think one of the most important pieces of the recovery journey is actually having that relationship with, if it's clinicians, coaches, whatever. There needs to be that support. Somebody needs to hold the hand through the process and go, yeah, it's okay, look, check in each day, make sure that they're actually on the right path, and just, again, keep them supported, because it's trying to do this in isolation is not impossible. I've seen it done, but it's certainly not the way that I would, expect that to work for 99% of people.
and that
Um,
in the takeaway of a number of things have been going on for a long time to get the deficit in place. And so
mm,
you've got to rebuild that. And if something took a year or 5 years or 10 years or has been going on for that long, you're going to end up with more fibrotic
work.
response in the body and so on. And you go to fix this stuff, then all of a sudden you get inflammation in a fibrotic area and there's not a lot of blood flow to carry the stuff away. So you can then you can cause local inflammation that it really gets in the way.
Mm,
And so the steps in the a takeaway of there's a there's a repletion step, and then there's an intervention step around the biochemical pathways and the health of of
mhm.
the tissues, and then there's the remove the offenders
The
part of
reservoir.
it, with the biofilms. And the
Mhm.
once you get robust flow and catabolic or anabolic activities going on, you get healthier gut lining, you get healthier endothelial lining, then all of a sudden you can peel off some of the inflammatory layers that have been there. And then on an ongoing basis, it's paying attention. So if you get another infection, then hey, that's a time to lay low for a little while it's building back up, versus saying, hey,
Mm.
I'm going to go right back to it and be at the edge of my energy envelope.
Yeah, and I think, look, this is kind of where it also highlights the importance of the data collection phase. And that's not just the markers. Look, again, we talked about the Lyme and some of the other species, and there could be toxoplasma and various other things. The infections that have got past the barrier, once you've actually fixed up the microbiome, once you've got the minerals back in, once you've got the systems working, you're going to then start seeing this immune activity and inflammation flaring up in all of, like, the pending jobs is probably the way that I would, term it. So any of the areas where there have been biofilms and, like, previous surgeries, old traumas, areas of infection, everywhere where there has been an unfinished or an incomplete healing process,
Right.
those areas are going to see inflammation. Those areas are going to have pain. And psychologically, sometimes that can be a little bit traumatic as well, because people think they're regressing. Oh, that was that symptom I had 12 months ago, or I haven't seen that thing for 2 years. I can't believe I'm back here again. And thinking that they're actually regressing instead of progressing. And that's a tricky thing. That's another, position where the clinician needs to be able to advise, or give the right advice around what's actually happening, take measurements, make sure that everything's going okay. But hypothetically, if there was an old injury from, or an old surgery from 10 years ago, where suddenly that area starts becoming inflamed and there's immune response and tissue healing, it suggests that 10 years ago that process never completed correctly. And there's a general expectation that no matter how clean the surgical theater is, that some biofilms, some seeding of some microorganisms is going to happen from any kind of trauma. Simply opening up the body leaves it exposed to potential for microorganisms to set up a residence. And at the in the initial state might only be a handful of cells, but in an immunocompromised person that can suddenly bloom. We can have, you leave food out on a overnight, you can see microbial bloom in a matter of hours, and the same thing is going to happen inside a tissue without a functioning immune system.
And you can end up in, when healing occurs, it can heal and totally resolve and you're back to a normal state, but it can also heal and resolve by creating scar and fibrosis. So within scar tissue, you may have a few blood vessels going through. If all of a sudden the tissue behind that is getting healthier and healthier, you're getting more blood flowing, and now you've got more inflammatory things coming into that fibrotic area, and so that can blow it out. So you can get you can get sterile immunity causing these issues as well as pathogen-driven inflammation. But I think the place of really the monitoring and checking, and some of this can be symptomatic checking, and some of it requires labs and biochemical markers to understand what's going on. What are you trying to treat? What is the marker that's specific to you as a person that you know is changing and is sensitive? Somebody might have their hair growing more. Somebody else might have the ringing in their ears lowering. Somebody else may be able to do more at a certain time of the day, or work for a longer period. A whole slew of things, and those can be really critical markers of, are you going forward or backwards? And that's really, I think, where we are in this process. We're coming up on a couple of hours here, and if we've done our job right, hopefully there's a better understanding of the underlying what's happening with the biochemical changes that get you down off that, or fall off the cliff into this place where you're metabolically stuck. Recovery is possible. It absolutely happens, not for everybody and not completely, but it happens with people even after years and decades. And the BornFree protocol is a structured science-based approach to go after this and work through the biochemical pathways and restoring the homeostasis. And there are other approaches that can be a part of it, or a mix and match, and there isn't one singular answer out there. But the today was designed to say, how do you take this list of 15 different pathways that make your head spin on the various biochemical items and the enzymes, and how they interplay with each other, and try to break it down into some pieces and protocol that can move forward to get back towards homeostasis. I don't know if you have any concluding remarks, Josh, and we can open it up for some of the questions. And
I think that was very well said. Yeah, so it's look, the body is always going to try to repair itself. That's the the end result. So everything that we see, everything that it's doing every day is trying to heal you. So it's just a matter of giving it the resources and removing the insults. And the framework of the protocol is there to help you see what's going on and allow you to empower you and the clinician to actually resolve those issues and move the baseline forward. And eventually you get from a point of having CFS and infections and everything else to maybe just having some infections to work on without having CFS. And that's the position to be in. Like the general population, oh, okay, yeah, I've got a flu, or I've got, I might have, a bunch of spirochetes in my blood, for example, and yet not be symptomatic. So it's basically allowing the baseline and resilience there that, just the average infection, or other background insults and toxins and things like that don't overwhelm the system. So, they can just run automatically and keep you safe each day.
All right.
yeah,
Thank you, guys.
yeah, go ahead.
Sorry. No, go ahead, John.
Oh, yeah, we're going to open it to questions. One piece I just wanted to highlight, this idea that there are things that are still around in long COVID or COVID and long COVID have been out there so much. It's when people talk about finding evidence of spike in the skull and in other places, the spike by itself is not necessarily an infectious particle, but it's an inflammatory generating particle that drives down some of these same pathways. So there are places where it may be very important to try to um, get that spike out, or if if somebody has heavy metal or mold issues, mold is more of a pathogen, but you've got to get the triggering item out as well as clean up the residual of what's left.
Yeah, there's aspects of the protocol that address like fibrin amyloid and spike and all that sort of stuff. But yeah, look, clinicians may have access to other, options like blood washing and various other things that are helpful too. And it
Yeah.
really just depends on the clinic and what's available as to what approaches you might use.
Okay.
Okay, so we will go into questions now. Sorry, John, that message was for Kat.
Yeah.
All right, so let's go into the first question, which is by an anonymous attendee. How many with current or past mold, fungi, mycotoxins issues have been helped by adding a local HEPA filter near their bed or where they spend most of their day, if you have some of that data or anecdotal information?
Anecdotally, I've had many people report benefits from HEPA filters, a good HEPA filter, and I think that's probably a tricky one because there are a number of HEPA filters that are not so good. Um, there have been some discussions in the BornFree Discord around that topic. There was a list of certain models and things that were helpful. Um, I would say, look, yeah, it's something ultimately that you'd want to address the environment more completely than just adding a filter. But as a general, yeah, sort of upshift in the overall level of toxins and 2.5, PM 2.5 particles and things, I would absolutely suggest that a decent HEPA filter is used.
And if you
And
if you look, there's some data in schools and classrooms with and without HEPA filters, not so much
Mm.
on mold, but in terms of time students are out or teachers are out of the classroom, and it's the same kind of thing. You keep the invaders out of the air.
Mm.
It's going to work better if there's not as high a concentration.
I'm not by any stretch of the imagination an expert on this, but a friend who is just recommended that the MRV on the filters is 13 and up for it to qualify as a good filter.
And that would
Okay.
be for the furnace filters. When you change your furnace filters, do you get the one that's a 7 or do you get the one that's the 13? And the 13 really can make a difference.
Got it. Okay, so next question from Jake. Can you explain why neurodivergence is so deeply connected to this model? Why it
Oh yeah.
exists as seemingly one of the first steps of entrance into the model?
Absolutely. That's a great question. Thank you for that. The metabolism in ADHD appears to be driven by the same opioid cascade, acetaldehyde opioid cascade, as CFS. So I think of ADHD as pre-CFS. So basically before you've actually ended up with the significant issues around the minerals and the fatigue and everything else. So you'll notice that people with CFS generally have, quite differing levels of ADHD type symptomology as well. And that's no surprise. What I've seen is ultimately that as you resolve the cascade, the ADHD symptoms are also dramatically improved. I would say there are still some things that are left behind, and I wouldn't think of them as being negative traits. In fact, I think that there are benefits. Like you still have the memory, the ability to go down rabbit holes. You still have, um, yeah, the ability to hyper focus and everything else. But you don't have the task perception paralysis. You don't have molehills being treated as mountains. You don't have, the chasing squirrel type effects and everything else. You basically have an improved functionality, if anything. I refer to it in the diagram as optimized, neurodiversity. Some would say it's a gift, actually. I certainly have no regrets as to, my state of operation post, CFS recovery. So, would I be an AU ADHD type? Yeah, I would say that that would be a label that you could apply. But I don't have any of the, the classical issues that I would normally associate with that.
And if you look at it from a brain architecture perspective, if you look across the spectrum of neurodiversity, you can end up with some of the autism spectrum disorders, and as it gets more severe, with higher density of connections on the post synapse or side. So basically, you can have somebody has a brain architecture that has an input nerve that says, hey, fire off, and then it's connected to a whole bunch of outputs, or somebody else has a longer connection between the different parts of the brain that might work with balance or thinking or planning or all the different parts of the brain and the circuits. And that architecture can set up for more of these issues too. And
Yeah, you've also got the lactic acid metabolism and signaling. It's like, as much as I was beating on the drum of, hey, lactic acid is, potentially bad. I mean, the reality is that lactic acid is great up until the point that it's not. So lactic acid is not just a currency, it's also a signaling compound, and it signals for myogenesis and neurogenesis as well. So somebody that goes out and runs marathons and dancing and is active and things like that potentially pushes into that anaerobic threshold and also has the benefits of, all of the lactic acid signaling. So again, it's too much of a good thing, then turns into acidemia and everything else. But you keep the cells that were created under those conditions. So much like an athlete or somebody that's had high levels of hormones, you have an unnatural advantage, if you like, for the rest of your existence based on the past experiences. That imprinting, is kept.
All right, next question. And the two-pronged approach toward restoring homeostasis. Would you also seek to kill off certain underlying triggering infections like Lyme and other
Yes.
co-infections? Or is the goal that restoring homeostasis itself would make the underlying infections go dormant?
I mean, I think the answer to that is stage 2 of the protocol, and stage 3 is aimed at clearing those infections. So when we collect the data at the beginning of the protocol, part of that is to identify the targets to then intervene with in stage 2, and it's then selecting the antimicrobials and antivirals and things that are relating to those pathogens. As far as the viral infections, if you fix the metabolism, hypothetically, you'd expect that the latent lytic, like the chronic reactivation problem, should be long gone. But you will still have reservoirs of pathogens and things to work with over time. Um, Look, there's work, post protocol work, that I'm thinking about as far as actually trying to clear out the latent cells, and that's something for the future. For the herpes viruses, there are some discussions around retinoic acid and various other things that will be very interesting in that context, I think, moving forward. There's other technologies like Draco, which is looking pretty interesting. You've also got supportive oligonucleotide therapy, which is amazing. But yeah, I've seen some very interesting results from that so far, and I think that's something that will be continue to be explored over the coming months and years. And then the Lyme infections. Well, yeah, I mean, anything that we can do to bring down the burden of the pathogens, in addition to the body actually being able to maintain and suppress growth of those pathogens, is what the end goal is. You want to get to a point where the immune system is able to continues to suppress growth of an existing infection. Like, I actually just found out recently that I still have Babesia, Bartonella, and a few other things circulating. And yet I don't have any chronic fatigue syndrome symptoms. I don't have anything else. So it's very, very interesting. But I think, like when I had COVID for the first time, I was wiped out for a good month after that. Like, I went back to exercise, and I, liver glycogen was non-existent. I actually passed out in the gym for half an hour after an exercise bike mishap. So basically the goal is, if you can remove the reservoirs, that is the ultimate goal. But at least getting to a functional status, much like the general population, where the tiny amounts of those pathogens and reservoirs that are left are not impacting your daily life, is at least the first set of goalposts. And then long term, we want to remove these things completely if possible.
All right, thank you. Anything else to add, John?
No, I think it is it's important to realize that people are walking around with latent infections that are not amped up, and then sometimes there are new things going on, and it's the multiple hits of there are going to be additional pandemics, there are going to be additional inflammatory infectious processes, and those take their toll.
All right, so
Yeah.
the next question is, some patients take a lot of cinnamon, that is an aldehyde, to perhaps regulate glucose or as an antioxidant. Any issues with this?
Okay. Well, yeah, it's a tricky one. So cinnamon also happens to be an antimicrobial. It does a number of things. They might also see a benefit in the context of chasing the dragon, for want of a better term. So when you're already dealing with a situation where you have tolerance and dependent systems being created by ebbs and flows of endogenous opioid synthesis, the cinnamon, much like certain forms of nattokinase, has the ability to inhibit ALDH2 directly. So is it problematic? Yeah, potentially. I think it really depends on the context of how much and what the status is of the acetaldehyde and everything else at that time, as to how much that's going to impact the cascade. I think it's something. I mean, I certainly enjoy some cinnamon, in my breakfast and things like that. I don't have ongoing problems with it. Other people certainly will see shifts in neurotransmitters. I've seen people where literally we can give a small amount of cinnamon and they are high as a kite. So it really depends on the person's situation as to how appropriate cinnamon's going to be.
All right, next question. I think it was partly answered, but do you have favorite methods for removing the insults, such as EBV, Lyme co-infections, and so forth?
Yeah. Look, the supportive oligonucleotide therapy, I think, is something that is probably going to hopefully be more accessible to people in the future. That is something that I think has a lot of merit. It really depends on the pathogens. I think the ultimate goal, like the initial goal with the herpes viruses, for example, is to get them back into latent state so that they're no longer part of the inflammatory cascade and the immune response, which then allows the immune system to go deal with any of the co-infections that are remaining. As far as Lyme is concerned, there will be some updates in the future around that. Again, the SOTs, I think, is probably going to be a very helpful intervention where possible. Beyond that, there's ongoing work towards protocols around combinations, cocktails of different anti-amoebal, antibacterial, and funnily enough, antifungal interventions, which have effects against Bartonella and Babesia and Borrelia and things like that. So yes, I do, and there'll be more information on that coming out in coming weeks.
Okay, so next question is, this is quite complex. Anyone applying AI to N of ones, individuals with severe ME/CFS, since everyone is different and continuously changing. Need to collect and interpret also real-time wearables, HRV, oxygen saturation, pulse, shaking, steps, etc.
Mm-hmm. So what was the question in that?
I guess the question is if if you guys know anyone applying AI for different iterations as people go through the steps based on the individuality and take it into consideration, the wearables that people are
I
using
would
and the data
love
from there.
that. I mean, ultimately, that would be something I would love to be seeing done. We're going to look towards aspects of that. I mean, the clinical trials being discussed at the moment, still not yet implemented, would be incorporating certain amounts of data collection, but certainly it hasn't had the opportunity to include LLM type, data analysis of that. I think that's something that could be looked at. As far as it being done from patient-led research, I believe there are some existing tools, but look, the problem is the data. Like some of the things that you'd want to collect would be like real-time lactate measurements, and simply the tools for that are not quite, widely available. There's things like what was the one? There were two different wearable lactate meters that were supposed to have been out halfway through last year, for example, and still are not available. I saw
They're
there was
almost
another.
there.
They're
Yeah.
almost
Oh,
there, and
They're
that's going to be
almost
really
there.
helpful.
Yeah, there's some
I
preliminary data on one of them. Yeah.
yeah. So that would be amazing. And as far as the rest of the wearables and things, I think that there can be some amazing data captured out of that as the tools, as the sensors get better. But just from the preliminary stuff with like heart rate variability and some of the other stuff that we can pick up. Yeah, look, I'm not aware of anything good at this point, but it's certainly something that I think could be built up with, with enough resources. I think we could cobble, that together from a lot of off-the-shelf products and actually do something, coherent with that. So I don't know.
And I
I'd be
think
happy to share that with people.
I think with the large language models, which model and when you're asking and how specifically you're asking really matter. And so,
Yeah.
and sincerely, I mean, I suspect a lot of people on the call are aware of it too, that if you look at and say, what's the answer to that now in the middle of July versus what was that answer in the middle of March or last December, they're very different answers. And we're on the cusp of it becoming that much stronger. And so I think if you are trying something and it's not working in terms of asking a question, try to add more specificity or more clarity of what you want the answer to look like. Not necessarily what the answer is, but what you want it to look like. And then also check various models. And it's startling how quickly it's moving.
John, do you have a hard stop just to manage the rest of the questions? I know.
I'm close to a hard stop at 5. I can go for a few minutes beyond that.
Okay, so we're almost there. So Richard, if you want to ask your questions, we can do so now.
Sorry. I'm Richard Lewis, alias Zero Gravitas. I'm a patient with extremely gradual onset ME/CFS, and I've hung out in the self-treatment and science watching communities for about a decade now, and the BornFree community for about 18 months with some slow progress. Thank you, Josh. So my first question, Josh, your website diagrams show many pathological mechanisms and vicious feedback loops. Are there core aspects that you expect all patients to have, or virtually all of them? Perhaps what you were presenting today is quite a accessible presentation today. Thank you very much. So like the acetaldehyde, endogenous opioids and stuff, but maybe not all of the trace minerals. Or for me personally, I feel usually I don't have the SNS overdrive. I don't have have that aspect. So sorry, long question.
It's okay. No, well, look, I think that's a very good question. So, yeah, look, the Cascade being presented today, I think was like one of the most common aspects that you'll see across, across the all the cohorts. There will be variability based on the individual mineral status. That makes a huge difference. The status of the microbiome, like the amount of acetaldehyde that's being absorbed, the pathogen profile. Everyone's going to have variability around that, but the commonality is going to be, what happens with the active B vitamins, and ultimately the acetaldehyde / opioid cascade. It's just the levels of each of these things, and ultimately how that's going to affect them. Pathogen profile and personality is something. So like somebody that doesn't have significant issues with, for example, Bartonella and Babesia and Borrelia, they all have individual impacts on different pathways, for example. Toxoplasma has different impacts on dopamine metabolism, and you'll get different effects on like the personality and then, the neuropsychiatric symptoms, for example. The locations of biofilms and microbiomes, other things like physical trauma, the CCI related issues, if there's blood flow issues to the brain, If you've got lymphatic blockages in different areas, you might have different, different like unilateral problems with a particular tissue. Um, yeah, there's a significant scope for variability with each person, and that's why the protocol goes out of its way to help everyone identify the key issues for that one person, and then once they've been identified, use them as objective and subjective markers for tracking progress. So yeah, it's not a one size fits all. It's a hey, here's a toolbox, and here's how you assess your personal situation, and then track the progress of your remediation.
And
But
I
yeah,
think
absolutely.
just amplifying those statements, I think on the clinical side of trying to, if you're going in to talk to your doctor and there's so many different dimensions going on, it can be absolutely overwhelming for everyone in that short visit, especially in the U.S. medical system where the visits are really partitioned off multiple times in an hour. And if you can understand what is your functional goal with specificity, with something that can get measured, or if you know that in your history you've got some lab values that have moved around, and you notice that they move with some of the functional changes you're seeing, that those can be really useful as hints as what might be important to track, and then to work on the general concept of what's happening here, which is to try to get those, the HAF and other things back into alignment. But you can't, if this has been going on for a very long time, you can't do that without making sure that the underlying raw materials are available. And so the stepwise process of repleting the raw materials and then going after trying to flip the switches is an important part of this.
Yeah, it's a question of how much you need to manually intervene in versus how much you can just
Yes.
give the system back its resources and let it do the work. Um, and just one thing I didn't touch on there, Richard, you mentioned the sympathetic overdrive. It's actually something that was interesting, speaking to my own journey with that. Similar to you, I actually didn't have a significant issue. I had acute periods of sympathetic overdrive during acute infection, but then beyond that, I wasn't dealing with that as much. In my case, there was additional layering of that because of earlier childhood trauma. I had certain adaptations where I have something that basically controls my adrenaline output. So to intense emotions and various other things, something steps in the nervous system and basically stops the sympathetic overdrive or the adrenergic spike. So it's an interesting thing. Like everyone's going to have a different journey or a different response to a lot of these things, and different adaptations around different insults and traumas. So yeah, variability.
Want to ask another question? I've got a second one
Yes,
lined up.
go ahead. Yep.
Yeah. Okay. So success rates is a very common question for patients looking at the protocol. Um, Can you share with us any informal indication of, what percentage of people you're expecting to make a significant remission at the moment using the protocol? Personally,
I
I know
today.
of quite a few in the Discord, and but then on like the other side, quite a few are struggling, and it's hard to get a feel of the overall balance from what's publicly visible.
Yeah, so look, the answer to that is that anybody that actively goes through, gets the right data, understands what the targets are, and remediates the targets, does well. There are people that
Hmm.
will get stuck because of reasons, either that they haven't got the funds to do the right testing. There are other people that get stuck because they have sometimes very fixed ideas on what things are, and they can't let go of those ideas enough to then, take a certain vitamin or do something. Like they'll go, oh yeah, I'm doing the protocol, but I'm not doing X, Y, and Z because I've got A, B, and C. And it's like, well, that's not the protocol. And that's one of the complaints that I've heard from certain angles is, oh yeah, Josh always says that, if you haven't seen success, then you're not doing the protocol, you're not doing it right. Well, yeah. I mean, ultimately, the protocol itself is a framework. If you have A, B, and C, do X, Y, and Z. And if you aren't doing those things because you have a belief structure that, oh, I can't tolerate that particular vitamin, or I can't tolerate that particular mineral, well, you've got a blocking point there that if your data shows you've got a deficiency and you're not addressing it, well, yeah, you're not going to be moving forward on that. So that's actually kind of one of the challenges. But what I can say is that from percentage or from a anecdotal tracking, the people that do go through and address what their data shows have a high success rate. And the key thing, I think, at the end of that is that nervous system, soothing at the end. Like if you can't get the sympathetic overdrive down after resolving the metabolic crises, then that has to be addressed. You can't get energy, you can't get homeostasis back until you get the body out of fight or flight, one way or the other. And if you can see in the data that that's not being caused by, deficiencies and anything else, then yeah, there has to be something else there that needs to be addressed.
And that's what makes it, makes it so critical that there is, the support and the guidance to do it, because we know that, it's also a feedback mechanism of when you are, perhaps too severe to make certain implementations and to be able to follow through on certain steps and to be able to determine what's a normal crash and what is a consequence of what's being done, and unfortunately there are no perfect answers to the challenges that we know that people experience, being the support system, being financial, or anything else in the process. What I can say is that the three of us and Anna are working on creating a platform to educate clinicians on all aspects of BornFree and other protocols, to really get deep into the biochemistry and the clinical applications of the dysfunctional pathways, and to be able to have more clinicians understand the complexities of this pathophysiology, and to be able to have more available to be able to guide patients through all of the steps.
Third question about clinicians and support. Yes, thank you.
Now, there's some more tools coming too. There's something really exciting, which I'm kind of getting close to finishing at the moment, which is an organic acid test automatic interpreter. And it takes a lot of the markers and then looks at groups of markers and does clustered weighting and things like that, looking at the pathways that create the metabolite and the pathways that degrade them, and then looking at combinations, like if there's 15 markers, that are all downstream of enzymes that require NAD to produce them, and 14 of them are low, then you've got a high probability that NAD is low, for example. And there's going to be all these different groupings and things. So ultimately, that tool will be available for clinicians and patients to feed in their organic acids test and actually get, more helpful data on what the expected status is of different intracellular minerals and coenzymes and things like that from that one report. So you'll get a lot of better value out of that particular panel.
Okay. Richard, do you have any other questions?
That's what I've got lined up. Thank you very much for
okay.
letting me ask.
Thanks for the good questions.
So really good questions. We are at a little bit past 5 o'clock. So, and the participants are also dropping because it's gone long. So we're gonna take a couple more questions. John, if you have to go in between, we'll just do this last two and finish up right here. And then I will take a screenshot of the rest of the questions left, and we'll try to post some answers with the YouTube when that's uploaded.
I've got a comment on one. I see one question there about ibuprofen and beta blockers for POTS, and how long do you need to keep using them? So initially you're saying with beta blockers, you're saying use a beta blocker to slow down the heart enough so it has a time to refill between beats. And by doing that, you increase the blood flowing out to the body. And at some point, as all the things we're talking about starts to reverse, you may not be in the place where the body's feeling it needs to produce higher levels of energy just to exist. And so so there definitely are places where you're not doing these forever, but some of it is I think the person's response and where they are on the healing journey ends up being a driver of that. And so I think there isn't obviously a single, and I don't think the person asking the question thinks there's a single time, but it's looking at saying, it might be that you have more energy, you notice your energy envelope is getting bigger in terms of being able to do things. Then you could try work with your provider to try lowering some of the drugs that are involved in the process and see what happens.
Yeah, I mean, I think that's probably it. Gauge that by the heart rate. Ultimately, if you start pulling out beta blockers and ivermectin, and you see a massive spike in the heart rate, maybe you weren't ready to do that yet. Bear in mind too these interventions, they have effects. It's not just for like the cardiac function, but we also have like metabolic syndrome type effects. So we didn't touch on any of that today, but there is a metabolic syndrome component to the disease model. And essentially, if you have, for example, upregulated fatty acid oxidation for various reasons, it's downstream of the beta oxidation, but then you've got problems with the pathway itself, and you end up with fatty acid pooling in the cytosol, then you end up with essentially a clash being created where the glycolysis pathway and fatty acid oxidation are both inhibited at the same time. So that clash is this metabolic syndrome. So while you're restoring the efficiency of the fatty acid oxidation pathway, having some sort of calming effect on the signaling might allow you to have better overall throughput through both of those pathways rather than that clash being created. But yeah, look, it's something that the clinician's going to have to make a decision on based on the individual situation.
All right, so we went a little bit longer on that question, so we'll do just one more. And Andrew asked, with how difficult it can be for so many to even get a single appointment with a long COVID specialist physician, how do you recommend getting a physician involved that would be capable of monitoring with the level of frequent testing and attention recommended in this protocol? I see that's one of the primary reasons why so many patients will lean into the DIY route, except for the most absolutely essential physician involvement. And before you guys go in there and answer as well, I'll reiterate the work that we're doing with the platform to train clinicians in order to address that issue. In the meantime, obviously sharing this with your clinicians to be able to get some of that understanding in there, and also the BornFree Discord, has a lot of information in there as well.
Yeah, I'm always happy to talk with clinicians while we're setting up the platform. So if you have a good GP and they want to learn, they're open-minded, and they want to, do more for their patients, then yeah, I'm always happy to help share what the protocol and what the disease model is able to help with. So yeah, happy to have conversations if you want to put the clinicians in contact with any of us, I guess.
And if you're talking to your clinician and they're having questions about it, they might not have familiarity with this approach or some other ones, that you can also check. One of the things is, so if you're in the process, or if you are providing diagnosis and treatment activities, you're taking responsibility for those activities from a medical, legal, and a licensure and an ethical perspective. So one of the things that becomes very, very important is kind of that trying to do no harm part of it, which ends up being active harm. And so it is, you may be able to get into a conversation in a visit to say, what things would be the concern on the clinician end of, and it might be lab values. So it might be getting some particular lab values to know what's what. It might be boundaries of heart rates. It could be any number of things. But those are the thought process that come up. It's people have once you start the treatment and diagnosis, there are a number of specific obligations, medical and ethically and legally, that come forward.
All right. Well, thank you, everyone. And thank you for everyone who hung in here until the end. We'll get this recording posted as soon as possible. And like I said, grab the Q&A and we'll do our best to post some of the answers along with the recording. Again, stay tuned on our website for the next event. And thank you, everybody. Have a great day.
Thanks, everyone.